Heav- Heavenly Father, thank you for today. Thank you for the idea you've given to us and the motivation to study. We depend upon your spirit to guide us. We also pray that you give us speed and understanding and the grace to retain what we have and what we learn and to apply it as necessary. Thank you, Father. In Jesus' name, we
Amen. So let us go to the number 31. All the following statements regarding diabetic mastopathy, we are done with this, right? I think we're done with it. I am done with this. Let's go to the next question. So let's start. We have 60 seconds or 1 minute.
It's not really clear.
Okay, let me
So,
show,
is it the question we want to answer now?
yes. Let me share my screen again.
Okay, a bit clearer. Yeah, let me see. Yes,
I know
this one.
I'll pick B.
My pep innocent soliciting. Hmm. Mm, well, if I want to guess, I'll pick D.
Let's see.
But microgynosis is a benign lesion but lacks epithelial cells. Cancer normally lack.
It has my epithelial cells, I would say.
He lack it. He doesn't have it.
Oh, that means I've forgotten. I've forgotten everything about my coronary adenosis again. Oh my goodness. Oh, so how do we not differentiate macrocycle from invasive cancer? Mm,
Okay, which one the answer there now?
D is your right. D. Let's see.
Why would that be two right answer in this one now? This one, okay, correct answer D. Okay.
Mm, how come I forgot that my coronary? Oh,
Is the benign? That's the point that I remember from it. It has secretion inside, like ducts,
God. God.
and the secretion. Okay, let me see. Like, even though it's benign, yeah, that's what I said.
Oh, it's wrong actually. D is wrong. The answer is E.
E is the answer. Okay, let's see.
Encapsulated papillary carcinoma from invasive carcinoma. Let's see. It's still wrong.
Oh, that's the answer. That's
That's still wrong.
okay. Let's see. Let me. What is their own answer?
That's why
Let's read this
all
again.
the answers so far are wrong. Let me choose B. Wrong. Uh-uh. Let me choose A.
It's
Wrong.
going to be between B and E. Ah,
The answer is actually C.
see. Well, let me see. Cancerization by Dr. Institute in an intraductal papilloma and an interductal carcinoma. That's true because intraductal papilloma, no, the P63 or the myepithelial stem stay both centrally, right?
Mm.
Sorry, Dr. Kanina, sorry, it stains peripherally, but not centrally.
Mm.
But sorry, so let me see. Ductal carcinoma in intraductal papilloma, the P63 will stain peripherally, but not centrally. But in intraductal papilloma, the P63 stain both central and peripheral. Let me now read the expansion. Are present at the periphery of the duct in both. Yes, but in the case of intraductal papilloma with ductal carcinoma, are present in the papillae and overlying cells appear cancerous, whereby are absent in the papillae of the intraductal papilloma carcinoma.
Papillary carcinoma. Hmm. You know what? This question is going to take us maybe 1 or 2 hours to resolve because we have to, in my opinion, we have to really dig deep into some of these things and really understand. If you can resolve,
It doesn't have to take way up to 1 hour. It,
what I'm saying is that we have to resolve it this well. Do you think you understand these things very well now?
we are building on what you already know before. What we need to know, like I said, you know what microdiagnosis is.
Yeah, what we need to know will not be that much. I agree with you. Mm.
Yeah, so we just need to know what is the
But
pattern of staining, which we
yeah,
actually know before. All these things we know
I
before,
think yeah,
just
we know
forgetting.
about. We're going to just quickly revise some of them.
So what we need to establish is the pattern of staining of P63 of the myepithelial cells in
I already know this. I already know the answer. I already know
yeah.
this. But I want to say that I think we need to not rush this question. We're going to
Okay.
go through it quickly. Okay, so do you know granular cell tumor of the breast?
It's like granular cell everywhere else.
Okay, so what are the parameters of granular cell tumor of the breast?
You is what you see in other cells. So you have is a benign tumor most time. So you have, although yeah, it's a benign tumor. You have round to over polygonal cells. Yeah, no atypia, have abundance what's it called now?
Granular cytoplasm.
Yes,
In terms
abundant
of
granular cells
markers, what markers would differentiate granular cell tumor from invasive carcinoma?
from
Invasive carcinoma. Let's start with the beginning. Let's look at this. Myopithelial immunostains are useful to resolve each of the following differential diagnoses. If you know this, if you answer this question correctly, you'll be able to practice independently to an extent, building on the knowledge you already have. Myopithelial cells and their diagnostic role. Myopithelial cells are present in normal breast ducts and lobules. Myopithelial cells are present. So they form a layer between epithelial cells and their basement membrane. Epithelial cells and their basement membrane. Their presence or absence is crucial in differentiating in situ versus invasive lesions, benign versus malignant nature of papillary lesions, complex intraductal versus invasive process. Common immunohistochemical stains are P63, smooth muscle heavy chain, smooth muscle actin, also smooth muscle heavy chain myosin, CK56. This is the major one. P63. This is cytoplasmic staining and P63 nuclear, cytoplasmic staining SMC. GATA3 is also nuclear. Calpulin, CK56. Those are another important things we want to do. But look at invasive carcinoma and granular cell tumor. Both invasive carcinoma and granular cell tumor lack myopithelial cells at the
Jonah,
periphery.
please hold on. I want to resolve something in a minute. Yeah,
Okay.
my children. Jonah,
Hmm?
okay, you went somewhere else. You
I'm here. Are you ready? Are you ready?
Yeah, I'm ready.
Granular cell tumor, mammographic appearance. Granular cell tumors can form dense masses on imaging that are speculated on their margins. And because it is speculated, it makes it difficult to distinguish it from invasive cancer. They may also have what we call pushing circumscribed margins. On gross appearance, they have a homogeneous white surface and a pushing border that contrasts very well with the yellow adipose tissue, as you can see here. Sometimes it's impossible with the gross eyes to distinguish between granular cell tumor and invasive carcinoma of the breast. On histology, granular cell tumor has a filtrative growth pattern, and the cells are kind of polygonal, and they have inconspicuous, distinct borders. This is low power anyway. And they invade dermal collagen. You can see the dermal collagen, or this collagen. They invade the dermal collagen around the skin of the breast, around skin adnexal tissues. Granular cell tumor that is surrounding the neural is kind of perineural one now. The tumors sometimes can be seen surrounding small nerves. You know that I think they arise from Schwann cells, right?
Yeah. Are you reading from this your expert from your this material too?
Yes.
Okay.
And
Yeah.
they have S100 stain positive. They stain positive for S100. What will invasive?
CD68 too.
Hmm?
I think CD68 too. The
I know PAS.
it also says possible CD60. You know what is inside there?
What's
The
it?
I'm not. Is it like? It's, I think it should be lysosome.
Okay, we got
The
that.
granules. That's
So,
one of the questions that they ask. Oh. I mean, I read question. That was the
so
granules there. What does it stand for?
which exam? What is that?
Eh?
Is it in West Africa?
In UK, I know that they do that in UK.
Wow, you've been studying UK past questions. That's good.
But I think it's something that is clinically relevant generally. Sha. I mean,
We'll
it's
get to
some
that.
of the things to know.
Okay, we'll get to that soon. So, but invasive cancer will not stay with S100. So that's one way to differentiate the two. This is solid growth pattern where they grow as cohesive cells, solid sheets of cohesive cells, divided by prominent collagenous fibrous septa that we have here. They can also infiltrate surrounding adipose tissue, giving the lesion an irregular border by imaging. That's what makes them speculated on imaging. They can invade the skin and the chest wall as well. Are they benign or malignant tumor? Granular cell tumor this one has a diffusely infiltrative pattern, and there are small clusters of cells that are dispersed in fibrous stroma everywhere and adipose tissue. Granular cell tumor. This is a epithelial appearance of a granular cell tumor. Cytoplasm is usually abundant. Are you there, sir?
And then
Cytoplasm can be very abundant, and the granules are going to be, what color will the granules be?
Eosinophilic, no?
Yes, and corresponding to numerous lysosomes, like you rightly said. So there are many lysosomes in this case. Larger lysosomes are surrounded by a lucent halo. Sometimes see larger lysosomes surrounded by a lucent halo. So it's a lot of lysosomes that form this granular cell tumor. Sometimes they may have a spindle cell appearance. This is a corneal biopsy. Cohesive sheet of cells, abundant foamy eosinophilic cytoplasm, infiltrating a collagenous stroma is the hallmark. Borders are irregular. Excision is generally recommended. That means a benign tumor. This S100 thing. S100 is a cytoplasmic stain. You know, S100 stains both nuclear and cytoplasm. So this is a nuclear and cytoplasmic stain of S100. Expression in virtually all tumor cells will stain S100. And here the cell on the peripheral nerve that also stains positive for S100. This is calretinin. Calretinin has both cytoplasmic and nuclear stain. Calretinin is also a marker of neuronal protein, neuronal differentiation. In all these proteins that have these markers, they have some their marks on here. You are right, they stain for CD68. You have already read so much. You're gonna take the exams.
Yeah.
Yes, you read, man. CD68. So why do they stain CD? Why do they stain positive for CD68?
What do you
CD60.
say?
Why do they stain positive for CD68?
Uh, that lysosome,
Yes. Note that CD68 is a marker for macrophages or histopath.
macrophages, yes. It's also a marker for macrophages.
But that's not the reason why granular cell tumor stains positive for CD68. It stains positive for CD. I wish we can do 10 hours today. Maybe if you don't do tomorrow.
Let's continue, say it goes. We can be resting in between, maybe short
Yes,
breaks.
let's finish the breast today. Let's finish it today.
Yeah, let's continue.
So let's say so CD68 is stained because of the accumulation of lysosomes in the cytoplasm of the tumor cells. So it's the CD68 here is not because it's a histiocyte, because it's of neuronal origin. It's because of the lysosomes in it. Are they cytokeratin positive or negative?
It should be positive.
They are cytokeratin negative. This is tumor. So what is the first marker we can use?
Which one is sorry.
Cytokeratin A1, A3. These are normal breast glandular tissue. Okay.
Okay.
These are benign breast tissue in our stain positive, but this is the granular cell tumor. You can see the nuclei, granular cytoplasm. Usually, it may be difficult on this place to appreciate it, but in real life, you will have, when you send for histology, the IHC, you will see that the area that is granular cell tumor on H and E, when you examine it under the microscope for IHC, the same area will be there under the microscope because it's the same slide section, but it will now be negative for S100. Sorry, negative for cytokeratin, whereas surrounding breast globules will be positive for cytokeratin. This is a gland. Granular cell tumor is not gland. It's not glandular. It's not a glandular something. It's abundant cytoplasm. You can see either nuclei. So all this area will be negative for cytokeratin. So far, what markers can we use to differentiate granular cell tumors from invasive breast cancers?
Yeah, we can use S100, the
S100.
because of the cell of origin. We can use CD68, the lysosome. We
This
can
is
use
okay, yes.
we could use that means that's positive in S100, CD68 are positive in granular cell tumor.
But negative,
Then
in invasive ductal cancer, right? Invasive
yes,
cancer.
yes.
Then what else? What is a very important marker? Very important.
Um,
Cytokeratin. A1, A3, cytokeratin.
yeah,
Invasive
cytokeratin.
cancers are
But
epithelial cancers. But
okay,
note
okay.
that granular cell tumor are not epithelial tumor. They are of neuronal origin, Schwann cell origin. So
Mm.
they're going to be negative for cytokeratin. Beta catenin also is good. Now, with that staying for beta catenin, yes,
Mm. Okay.
because they do what? Because so they are positive for membrane membranous beta-catenin as an adjacent normal epithelial cells. The protein is also found in normal Schwann cells.
Beta-catenin is standing for.
Beta-catenin can stain Schwann cells. Okay, it stains the membranes of beta-catenin stains the membrane of granular cell tumors, right?
Okay. Now,
Yeah.
which tumors do you come to your mind when it comes to beta-catenin?
For breast or non-breast. For beta-catenin, I know that
Like soft tissue.
for OBGYN, I know that I can't remember. Okay, soft tissue.
I think I need to confirm too, sure. But I think maybe something like nodular prostatitis. But yeah, but soft tissue. Some of
Soft tissue and GYN tumors that I think there's this tumor that is very, is
the
this
tumor.
not serous carcinoma, is the other one, clear cell carcinoma, is positive for napsin A. I don't know for beta catenin. And GYN tumors that are positive for beta catenin. Here's the best way to learn. You have to keep going back and forth, otherwise you forget. Desmoid type fibromatosis, solitary fibrous tumor, SFT, synovial sarcoma,
Okay. Yeah.
low-grade fibromyxoid sarcoma, endometrial stromal sarcoma,
Maybe it's only the fibrous tumor that is not everything.
endometrial carcinoma, uterine and ovarian. Membranous cytoplasmic. And sometimes you have to know if it is membranous, cytoplasmic, or nuclear. It's very important for, like this endometrial stromal sarcoma, is nuclear beta-catenin. The fact that it's staining positive for nuclear beta-catenin doesn't show it's positive. You have to know some tumors have cytoplasmic staining positive for nuclear beta-catenin. Some have nuclear staining. Some have cytoplasmic staining. So you have to know. For granular cell tumor, it is you can see the membranes here. It's a membranous staining for beta-catenin, at least. So, and it's adjacent to normal epithelial cells. These are epithelial cells. The protein is found in normal Schwann cells. Beta-catenin is found in normal Schwann cells. That's why it stains positive. What tumor can mimic this granular cell tumor? It's called apocrine carcinoma. Do you know anything about apocrine carcinoma? Apocrine carcinoma will have a lot of eosinophilic cytoplasm, just like granular cell tumor. The reason that granular cell tumor cytoplasm is eosinophilic, granular, and foamy. This is not very granular, so it's going to be very pink cytoplasm. However, apocrine carcinoma is a real cancer, so you have a lot of mitotic spindles. You will not see mitotic spindles in granular cell tumor, which is more or less benign. Are you with me, sir?
Yeah.
Not only that, in apocrine carcinoma, you will say DCIS. In DCIS, I should have a lot with apocrine metaplasia. DCIS will tell you that this is a breast cancer. Do you understand? DCIS always helps you if you have a breast lesion to tell you that if there's an in situ component, then this may be a real cancer. Do you understand? So that may help also in differentiating the two. And then there's some invasive lobular carcinomas that have histiocytoid appearance. The cytoplasm will be vacuolated, but not finely granular. This is vacuolated cytoplasm. Have you heard of falciparum cytoplasm? Found in Chordoma.
Yeah, Chordoma.
That thing is where the granular cell tumor. So let's continue. So this is vacuolated. Now, silicon. The other day we studied silicon, but you were feeling sleepy then. Then you have more vacuolated cytoplasm. Secretory carcinoma will have secretions. We also resemble it, but secretory carcinoma will form tubules and have secretions. And secretory material is not going to be found in granular cell tumor. Granular cell tumor, although the secretory carcinoma look eosinophilic, but the secretions and the pleomorphism will give it away. Secretory carcinomas, unfortunately, are positive for S100 also. However, what will you now use to differentiate secretory carcinoma from granular cell tumor?
68.
Cytokeratin. It's more important than CD68. Cytokeratin. Remember that secretory carcinoma is a epithelial cancer, so it's going to be positive
Yeah.
for cytokeratin, but negative in granular cell tumor. Metastatic melanoma can resemble anything, right?
Yeah.
Metastatic melanoma will it be S100 positive?
What do you say?
Will metastatic melanoma be S100 positive?
Yeah, it will be.
Yes. So it may mimic granular cell tumor. So how will you differentiate it as a pathology?
By HMB 45.
HND 45 melan, A other ones will be negative in granular cell tumor, but continue to be positive. You do a panel.
Mm.
And those other ones will continue to be positive in melanoma. And melanoma has prominent cherry red nucleoli sometimes. Not only that, cytokeratin should be negative in melanoma. Alveolar soft part sarcoma will be PS positive and diastase resistant. But the thing is that alveolar soft part sarcoma will have crystalline deposits, while granular cell tumors look diffusely positive.
Alveolar soft parts,
Part
right?
sarcoma. Yes, alveolar soft part sarcoma will be PS positive and diastase resistant. I read it before, but trust me, I forgot
So
again.
what is the
Hmm?
crystal? It has crystalline deposit, right?
Yeah, look at this crystalline deposits around the nuclei also. Perinuclear crystalline deposits. Granular cell tumor doesn't have that. Part necrosis.
Jonah, is it not better for us to be using this material than
Which one?
just ChatGPT?
Which one?
Or
This
just
material. It's a combination. It's a combination that we are using now. Combination
okay,
is the
okay.
best. That even this material, if it can be bulky, but ChatGPT simplifies it. This material is for visual. Do you understand? We have to
Mm,
see a lot of pictures, right? I agree
yeah,
with you. So that's why we are using this material, a lot of pictures. But ChatGPT will give us texts. It's not good for us to be, it's like studying anatomy without atlas. So
mm,
ChatGPT is
mm.
like, has no atlas, but it gives us a lot of visuals. You have been combined, actually, you have been combining both of them all along.
Okay.
This is CD68 again, granular cell tumor. Metastatic melanoma. We talked about the melanoma already. I don't want to bring it up again. Like I said, metastatic melanoma will be cytokeratin what? Negative.
Negative.
Can cytokeratin differentiate metastatic melanoma from granular cell tumor?
No,
Why?
both of them are negative now.
Perfect. Both of them are completely negative. Very good. I was even saying before that granular cell tumor is positive. Can you imagine? So sometimes the nuclei can be a junction of nuclei can be overshaped. This is not so now one thing about look at this is like some large lysosomes have perilysosomal halo, like this one in granular cell tumor. Look at this. Large lysosome lysosomal halo. That's one thing that may help you. An over nuclei. S100 positivity, So we know a lot of these things. Apocrine carcinoma, we mentioned that already. You see DCIS, it will see more significant atypial mitosis in it. This is invasive lobular carcinoma histiocytoid appearance. What single marker will help you to differentiate it from granular cell tumor? This invasive lobular
Which one?
carcinoma. This is an invasive lobular carcinoma that has histiocytoid appearance. I almost resemble granular cell tumor. It's what will help you differentiate it. What marker?
Well,
Mm-hmm.
cytokeratin. No.
Cytokeratin.
the
Benign double
cytokeratin.
carcinoma will be cytokeratin positive, but negative in granular cell tumor, A1, A3.
Mhm.
Of course, ERPR, all those things will be negative in granular cell tumor. Understand? So, and this is invasive lobular carcinoma. I see the like these are pods of invasive lobular carcinoma that will be positive for, that will be negative for E-cadherin. Remember E-cadherin.
There's a point I want to note. So we'll still go back there. Relevance of my epithelial cells. I know I know it's in the way, but I just want like the summary in
Yes.
this ChatGPT.
Mm.
The application, there are like 3 points. In ductal carcinoma, in papilloma and all that. So we'll go back just for me to
We're not
refresh.
going, we'll go back. We'll go back. Our main page is here.
Hmm.
The
Let's
problem,
continue.
the problem right now is that we want to rule out all these differentials. It was a little confusing. So we just want to
Yeah,
refresh our minds quickly on it and see more pictures. Remember the
yeah,
pathology, the more pictures we see, the better for us. So it's a site
Ben.
appearance. So this is invasive lobular carcinoma. This is granular cell tumor H&E. They have abundant cytoplasm, granular pink cytoplasm. Apocrine carcinoma can mimic this. But what again will differentiate apocrine carcinoma from this?
About the atypia
The
in Apricant
ATPR,
carcinoma,
yes,
is is it is the
this right.
cytoplasm bubbly?
The protoplasm sometimes looks similar. So you can use, but the ATPR, mitosis, and all this will help you. This tumor, granular cell tumor, is a benign tumor. So you don't see that number of mitosis ATPR. You cannot see mitosis and ATPR on a very bubbly cytoplasm with large and with this kind of cytoplasm that's abundant cytoplasm, pinkish, and they now call it granular cell tumor. That would be looking for trouble. You understand? So it has to be
Hmm.
benign for you to call it granular cell tumor. And sometimes you will see for apocrine carcinoma, you will see apocrine metaplasia. There's what we call it typical metaplasia. You will see DCIs, some adjacent structures that will tell you that this is a cancer. This with you will see the in situ component of the cancer at times. The question I
Hmm.
have is this: does apocrine carcinoma of the breast stain positive with cytokeratin?
You should be of epithelial origin.
Stain positive for what? Cytokeratin.
It should be.
Yes. So
It's
this is
epithelial origin.
yes. And IEC can be helpful in determining the correct diagnosis. So cytokeratin actually, in general, we say that cytokeratin helps us a lot to differentiate granular cell tumor from what? Epithelial cancers of the breast, right?
Yeah.
Mm-hmm. So granular cell tumor, diffuse nuclear, granular cell tumor, S100. S100 has diffuse nuclear and cytoplasmic. Expression of S100 protein can be helpful in confirming the diagnosis and support. Mm. We already know, we looked at this. So a lot of things can mimic each other in real life. Do you understand? That's what they are showing us here. Are you with me, sir?
I'm with you. I'm
When
with
you
you.
see all this abundance, these things, some of them are, abundant. These are from high centers that have high volumes of this thing, and they have had confusions in the past. That's why they are showing us all these things to help us know that a lot of mimics, like invasive lobular carcinoma. There's a type of invasive lobular carcinoma called what? Histiocytoid pattern that has a lot of abundant cytoplasm, prominent nucleoli that may make you to think that this is will make you to think that this is apocrine granular cell tumor. But what will help you? Of course, the prominent nucleoli, the TPR prominent nucleoli, the cytokeratin. How will you differentiate invasive lobular carcinoma from invasive ductal carcinoma?
Loss of each other.
Perfect. And what of P120?
Oh, that one. Okay. P120 is a membranous stain.
Yes. that
So
is normally anchored to the membrane by E-cadherin. So when you
yeah,
lose E-cadherin, what happens to P120?
it go to cytoplasm.
You now have cytoplasmic staining of, yes, for
In
P120. Cytoplasmic staining.
for lobular carcinoma is P120 is what is cytoplastic stain, right?
Yes, and E-cadherin membranous negative, right? But E-cadherin
Yeah.
negative, P120 cytoplasmic staining.
But
What of
but
invasive
in
bladder
facing
cancer? Yeah, what
in
will you say?
facing ductal cancer, then P120 is membranous stain, right?
And E-cadherin is what?
It's present, it's still
It's
there.
also membranous. Both of them are
Um,
membranous things. You have double membranous staining. P120 will be positive membranously. E-cadherin will be positive membranously. Once it's invasive lobular carcinoma, E-cadherin will be negative completely. But P120 will be what? Cytoplasmic.
yeah.
Okay. Granular cell tumor is rare. It's just a summary of what we. This is just text. It's rare, usually benign soft tissue neoplasm. What's the origin?
It's Schwann cell.
Schwann cell neural crest derived. Historically, granular cell myoblastoma, though the term is now outdated. No, we don't outdated terms. It's very rare. 1 in every 200 breast carcinomas, 1 in 1,000 of all breast tumors, 5 to 15% occur in the breast, and common in middle-aged women, 45 to 55, not very young people, but it can range in any 17 to 74 years, occur in both sexes, male and occur in both sexes. 90% of it is female. Higher prevalence and onset in women of African descent. So African American women may have more of granular cell tumor. So the genetics are ATP6AP1A, sorry, ATP6AP1 and 86 ATP6AP2. 60 to 70% of cases which regulate endosomal pH. Lots of functional mutations lead to lysosomal accumulation. The thing is that this ATP6AP1 and ATP6AP2 regulate endosomal pH. And when you have mutations, endosomal pH will be affected. And the loss of function of this endosomal pH regulation will lead to lysosome accumulating and not being degraded or producing granular cytoplasm. There are rare associations with neurofibromatosis type 1, Noonan and Leopard syndrome, via PTPN11 mutation, Banaye, really, Ruva, Kaba syndrome. It is rare. Fair, let's know the normal things first. Usually, it's going to be a firm, palpable, usually painless mass in the upper inner quadrant of the breast, corresponding to supraclavicular nerve territory. So you know the supraclavicular nerve, you know there's a neural crest origin. So you don't expect this tumor to be in the upper outer quadrants. You don't expect it to be in the lower quadrants of the breast. The supraclavicular nerve, just underneath the clavicle. Are you with me, sir?
Yeah.
So they arise from underneath the nerves right underneath the clavicle. So that would be most upper inner quadrants, supraclavicular nerve territory. Let's get a picture of that quickly. We won't take time, just 1 second to see if we can get a good picture of it. Let me see if I can. Oh, very good. So if you look at this is the supraclavicular nerve. So this is the brachial plexus, like near the upper part of the clavicle. Somewhere around here is where it's going to arise, because that's where the Schwann cells will give rise to granular cell tumor. They can mimic carcinoma clinically, causing skin retraction, chest wall adherence, circulated mass on mammography, hypoechoic mass with posterior shadowing in ultrasound. Architecture, solid, well demarcated, but infiltrative sheets of nerves. We've seen that already. Abundant cytoplasm that is granular, PAS, and diastase resistance. Why is it diastase resistance?
Because it is that eosinophilic thing, it's not glycogen.
Well, I didn't get that.
I said it's not glycogen.
Yes. It's lysosomes, not glycogen. So it's going to be PAS, that's this resistant. The nuclei will be small, round to oval, bland. Occasional pleomorphism may be allowed. Borders speculated on imaging, infiltration, connective tissue, growing, it can grow perineurally to show that it is arising from Schwann cells. It mimics carcinoma radiologically and even microscopically. IHCs already saw S100. We saw CD68. We saw carotene, which is a neuronal marker. Other neuronal markers are neuron-specific enolase. SOX10. SOX10 is also important for Schwannian differentiation. So it's going to be positive for SOX10. What is SOX9 for?
I don't know something.
SOX9 is for chondrogenic differentiation, cartilage. Sometimes knowing what a marker is originally intended for helps also for first line principle to reason what a cancer can be coming from. So cytokeratin is a very big one. See the way they highlighted it. It's negative. And it's crucial to differentiate it from carcinoma. If there's only one marker you should do, because some places, private job, private business, private practice, they want to do to make a lot of money with minimal expenses on the patient. If there's only one marker you want to use, apart from other things, ATPR, H&E, what should it be?
Cytokeratin.
Yes, not myoepithelial cells, because that they have to differentiate it from carcinoma. ARPR HER2 will be negative also. Like catenin will be positive and it's going to be membranous, but that's not too helpful. 2% can metastasize. The other 2% will have necrosis, spindle cell morphology. This one will be for experts. But look at all these differentials already. Look at this already. Treatment is complete surgical excision with negative margins. Prognosis, benign in 99% of cases. Malignant transformation is very rare.
Ideally, you should know the criteria for malignant tendency. You just say for experts.
I don't know.
But
I don't think so because it's very rare.
it is just those normal things that should give us tendency for malignancy, and then spindle cell morphology. Necrosis, mitosis, high nucleus, all those things. They are things that point to malignancy, but in addition to spindle cell morphology.
They also give you
Then,
the classifications. They give you scoring
yeah.
system, which I don't think we need to learn. So these are not for residents. Anyway, I agree with you. Your typical first line principle. Understand? So that's enough. It's benign,
Mm.
0 to 1. I don't think we need to memorize this. Honestly, if because it's a very rare tumor, number one. And to even metastasize, it's so rare that it's for physics. These are in the USA, they used to grade our exams. Some are for fellowship, some are not for residents. This is fellowship stuff.
Okay.
So let's go to the second thing. We looked at this already. Oh, what are the markers? What are the rules of my epithelial cells?
In situ. Okay.
Versus invasive lesions, benign versus malignant nature of papillary lesions, complex introductory versus invasive process.
In
At the end of
situ.
this, we'll come and look at this to make more sense.
Benign versus malignant.
So microgranular adenosis versus well-differentiated invasive carcinoma. I crave your indulgence to quickly revise microgranular adenosis, because I've forgotten key things again. You still remember, not like me. We will not spend much time, I promise you. I remember something, but it's so shocking that I can't remember the most important thing, which is that it lacks. This writer is a good writer.
The most important thing is that it is benign, but it lacks myoepithelial cells, which is unexpected for a benign lesion. It
Yes.
has eosinophil, it has secretions. They are bland looking glands.
But then this is it. It can have infiltrative growth pattern. That secretions in it, just one layer. And it has no stromal desmoplastic response.
Mm.
You see luminal secretions, single layer of microglial cells, and secretions are normally eosinophilic. Okay. And the tumor will be surrounded by what we call basement membrane-like material. H and E. This is the IHC for microglial diagnosis. What IHC can we do? Hmm?
It should be negative for my epithelial marker.
Yes,
It says 100
S100.
positive.
Yeah. The basal carcinoma will be negative for S100. What other breast tumor that's not malignant can be S100 positive?
We just talked about granular cell tumor.
The granular cell tumor. Mhm. What else will differentiate it from basal cancer? Apart from
Those hormonal marker, ERPR, then
will be
R2.
positive invasive cancer, lumina A especially, but negative in microglial adenosis. Whereas S100 is a very important marker. Tepicaratine will not help. Well, I think both of them will be positive. So the question is this. This is what can you see here? Microglial adenosis that is positive at the margin. Should you re-excise or no? It's highly debated. Some will say re-excise, you may recall, some say don't re-excise. You don't know. But report it. This ER, PR, all negative. Why are they negative? I don't know. These are luminal cells. Now, why are microglial cells negative for P63? Because they are luminal cells.
Okay.
Now, remember that microglial is normally surrounded by basement membrane-like material. So if you do collagen 4, IHC, collagen 4, while the basement membrane, you see it surrounding the glands, like here. But it's a red thing, maybe for research purposes, but I don't know. P63.
Then there could be precursor to some triple negative cancer.
Yeah, the basal-like double negative, right? Look at this. This is P63. P63. Is it positive or negative? You will see P63. What kind of marker is P63?
Is a nuclear marker.
The nuclear marker. Sometimes if P63 stains cytoplasm of a cell but doesn't stain the nucleus, it's not positive. Because sometimes we see this dirty appearance around the microglial adenosis, but the nuclear is not staining. That doesn't mean positive. This is an example of a clear nuclear staining. Very dark, very dark, very dark. Not this brownish cytoplasmic something. Here. It may confuse people at times. Both of them are positive for cytokeratin. Cytokeratin is normally cytoplasmic. If you look at this is a combined stain. Sometimes we do combination of stains. This stain has both P63, which is dark brown, nuclear stain, and cytokeratin, which is cytoplasmic stain. If you see here, this is a normal cell having both P63 outside, nuclear, and inside luminal cells stained with cytokeratin. Yeah, luminal cells are stained with cytokeratin, but they don't have a corresponding outside basal myepithelial P63 staining. This smooth muscle heavy chain myosin. You see it. These are normal cells. These are macrogranular adenosine cells, negative cytoplasmically. It's cytoplasmic stain for smooth muscle heavy chain myosin. This is a typical microgranular adenosis that start having some level of atypia. Mitosis. Sometimes invasive cancer can even get associated with microgranular adenosis. Okay, this is an invasive cancer, clear invasive cancer. This area of microgranular adenosis. And the thing is that when you do ER/PR, it will stain this invasive cancer, but be negative in this microgranular adenosis that is adjacent to it. But microgranular adenosis will be positive for what will be positive for
S100.
S100. It's S100 staining. Tubular adenosis. Tubular adenosis can also mimic it, but tubular adenosis will be positive for epithelial cells. Ischemic cell carcinoma can mimic it. Podolar secretions, and they will show positivism for lysozyme, and I don't want to go into that. And the S100 positive. I mean, ischemic cell carcinoma is a very difficult cancer to differentiate from this. I don't want to go into that now because of our time. Obviously, tubular carcinoma, obviously, ductal carcinoma, ARPR, carpolin. Carpolin is myopathy marker also. H&E is a very difficult type. Triple negative breast cancer. Triple negative breast cancer too can be difficult, but S100 will help. S100. So diagnosis is rare, benign epithelial proliferation, small, characterized by small round infiltrative tubules dispersed in fibroadipose tissue. No epithelial layer, yet they are surrounded by a basement membrane, which can stay positive for collagen 4. The S100 positive, but ER/PR HER2 neo triple negative. They are considered a non-obligate precursor to certain triple negative breast carcinomas, like the basal cell, like basal-like type. There are three types of microgranular adenosis. We have the classic pure type, which is benign with no atypia or invasive carcinoma. Atypical type that shows architectural and nuclear atypia, and the carcinoma arising from microgranular adenoma, which can be the triple negative breast cancer that arises from it. We looked at the size can 1 to 20 cm. Sometimes it may have absent secretions or reduced secretions. That's for the atypical type. Mutations are TP53. And they have gain in 1Q, 2Q, 7P, 8Q, and lots in many other things. BRCA1, PIK3. These are not very strong, I would say. Atypical microgranular adenosis may be misinterpreted as a triple negative breast cancer and may lead to neoadjuvant chemotherapy. So the only way to differentiate, how do you differentiate atypical microgranular adenosis from triple negative breast cancer?
We can use S100, then hormonal receptors. So ER.
Those also be negative in both triple negative and microgranular adenosis.
Hmm?
Atypical microgranular adenosis will still appear on H&E to an extent well differentiated. You will still see tubules. In triple negative, that is really triple negative, I don't think you will see tubules anymore. Right? It's going to be a very poorly differentiated cancer. The S100 is a good way to go. S100 will let you know that this is atypical microgranular adenosis, tubules with atypia, with mitosis, and negative for P63 and co, with secretions inside or diminished secretions inside. So S100 will help in this particular matter. Ethnic cell carcinoma, do zymogynes and all that. Okay, let's come back to this. So what we read here is that Both microgranular adenosis and well-differentiated invasive cancer lack biepithelial cells. Their distinction is based on architectural pattern, infiltrative growth in carcinoma, stromal reaction. Invasive cancer will have desmoplasia, while microgranular adenosis will not have desmoplasia. Microgranular adenosis will be S100 positive, ER negative, and CK7 positive. Why? Well, we didn't even see CK7. Why invasive cancers will be S100 negative and AR positive. Again, my epithelial stains will help. Because most of them have no epithelial stain. Let's come to D before we come to the answer. Microgranular adenosis and carcinoma arising in microgranular adenosis. Will P63 help in this case?
Both of them are negative. No.
Yes, because they are absent in pure microgranular adenosis and carcinoma arising in microgranular adenosis. What will tell you the transition to cancer, like you rightly mentioned at that time, is marked cytologic atypia, increased mitotic activity, solid and cribriform architecture, tumor grid. Carcinomas arising from microgranular adenosis will be grade 3 tumor, not this grade 2 or thereabout. They'll be poorly differentiated. They will not have that amount of tubules. Option E, encapsulated papillary carcinoma versus invasive carcinoma. Can you think
Okay,
about encapsulated papillary carcinoma?
encapsulated. Okay, black myopicels both in the papillary
Yeah,
pores and around the lesion.
they look like DCIS, but DCIS will normally have epithelial cells in the outside. But encapsulated papillary carcinomas will have papillary core. They now have a very thick fibrous capsule surrounding it. Do you remember?
Yes.
And they will lack epithelial cells outside. So that's one thing. So both of them will lack P63 staining. Okay. So let's now list us now to come to number D. No, number C. Cancerization of intraductal papilloma by DCIS versus intraductal papillary carcinoma. So before we go to that, let's quickly look at this papilloma, large duct and small duct review, and then we'll come back and look at this. This is the main text that we will be waiting to come from. So this is a large duct papilloma. These are papillomas look like in ducts.
Okay.
And are normally associated with nipple discharge. And usually the large duct that are close to the nipple. They look like nipple area. They can twist on the stalk. And when they twist on the stalk, that will lead to infarction of the papilloma. There can be intermittent obstruction. And that can result in episodes of spontaneous discharge. You may be bloody. So when they discharge, you may undergo some ischemic necrosis and discharge. Large duct papilloma. You can see that fibrovascular curves. This is a large duct. And
Okay.
there's a stalk here. So one thing about papilloma, intraductal papilloma, there will be a cystic space or a large duct. I may not even have my epithelial lining. Who knows? I don't know. And there will be a stalk where they are normally attached, a broad one. And the stalk will not be like pedunculated, it will be a broad stalk. And the appearance of intraductal papilloma, is it going to be homogeneous or heterogeneous?
A large dot, loud dot. It's going to be heterogeneous.
Yes, because this is a benign lesion. It's not a clonal proliferation. So you see some areas have more stroma, some areas have less stroma. So it's going to be heterogeneous appearance. Papilla with fibrovascular cores of varying thickness. This is very thick fibrovascular core, very thin fibrovascular core, and varying hyalinization. Okay, so that will help us a lot in knowing the two. Now, this is an ultrasound appearance. You see a lobulated mass. Is this one lobule, another lobule, another lobule, projecting into a cystic space? You see this large ductal area, duct attachment. These are papillary fronts of benign papillomas with well-developed central fibrovascular cores. And the papillae are lined by two layers of cells. The luminal cells, okay, and the myepithelial cells. The luminal epithelial cells are these, and the line myepithelial cells, two layers. So are you there?
Yeah, I'm with you. I'm with you.
This smooth muscle actin, what kind of marker is it?
It's a myopithelial cell marker now.
Yes. But it can be difficult in papillomas. But it can stain blood vessels as well. And blood vessels are found in fibrovascular cores and myofibroblasts. This is a blood vessel, for instance. They are not the best. I'd rather go for P63. This P63. You see them staining the myopithelial cells in the papillary cores. And they are nuclear positive, making it easier to identify. So the luminal cells will be negative. And they also stain the periphery of the papilloma. This is the periphery, this is the surrounding periphery of the papilloma. They will stain it positive. This muscle actin also, benign papilloma. This muscle actin, I don't know why they are showing so many of it. P63 is always the best. This apocrine metaplasia. So what are the features of apocrine metaplasia on this image?
Sorry, what's the question again?
What are the features of apocrine metaplasia on this image?
The future of epochromatoplasia. Okay.
Mhm.
In epochromatoplasia, this is the third feature, right?
No, on this H&A.
Okay. Eosinophilic cytoplasm,
Yes.
but
This is
there is ATPL.
no, this is not a typical apocrine metaplasia. This is just normal apocrine metaplasia. It has
Okay.
abundant eosinophilic cytoplasm. What does that imply? That it's a heterogeneous lesion and it's benign. To see apocrine metaplasia, here is blue, here is apocrine metaplasia with eosinophilic cytoplasm. And show that this heterogeneous nature tells you this is a benign lesion. That is, I mean, there's no mono, there's, it's not, there's no, there's, this is not a non, this is not a clonal proliferation. Sometimes it can be displaced. Let's see. This is UDH. UDH may be architecturally complex. So sometimes UDH may have some, complex nature and we won't make it to taken off any. Probably What will you see what stain will help you tell you that this is UDH instead of papillary carcinoma? So instead of papillary,
What's the,
can
sorry, I didn't
differentiate
get
what stain can differentiate UDH from the rest of the lesion?
the doctor.
Usual ductal hyperplasia. It's benign something.
Yeah, that was certain person.
CK56, remember,
Okay.
it will show you mosaic pattern.
Yeah.
It will stain. That was used a lot in DCIs. It will stain my epithelial cells quite all right, but inside will be mosaic like this. But you see mosaic pattern in this kind of lesions is UDH.
Mhm.
This is ADH. How will you differentiate ADH from UDH?
Mm,
Size.
monoclonal nature
Both of them look
or
very the same, but the size. What's the size?
the site or what?
Anything less than size, anything less than 2 millimeter is ADH, no matter how bizarre it is looking.
Okay, that differentiation from DCIS, no?
Yes.
Not from UDH.
No, UDH will be polyclonal now.
Okay.
ADH will be monoclonal, look like DCIs.
Okay. It's less than 2 mm.
Yes.
What is the
This is
pattern of CK56 staining in ADH? You know, in UDH, it's mosaic pattern.
mm,
What's the pattern in
in ADH
ADH?
and DCIs, it will be negative, or it will just be dark staining. It will not show mosaic pattern. Look at the picture. Yeah. CK56 DCIS versus UDH. Let me see. Mhm. This is UDH. I want to see. I want to see if I can get a very good contrast between the two. You can see this is papillary DCIS. When we did the staining, some focal
Papillary
areas
DCI,
anyway.
papillary DCIS, the periphery stain positive for P63, but the fibro core center or the
No, for the
central.
DCIS, for the CK56.
Okay, CK56.
Yes, but here, I think here, we don't know about here, but most of it is actually negative. Let's see. It doesn't have the mosaic pattern. Let me see. Mosaic pattern. I want this picture that can juxtapose both of them.
This one now, is it Google or from your
It's Google. It's Google. We are 65. Huh? I just showing me. Let me see. I think this is CK56 for mosaic pattern. Anyway, I shall know that it doesn't stay. So it doesn't stay mosaic pattern. That's what we can go take out from here. Let me see. Look at this thing. So here we have the ADH and DCIS consisting of clonal luminal cell population that are positive for low molecular weight keratin. You see, low molecular weight keratin. In contrast, areas of hyperplasia. You know, some of these tumors may also have areas of hyperplasia inside. High molecular weight. I'm not so sure, but let's just continue. Would have a very good picture. For sure. This piece is a tree. They're showing this is sclerosing, this is a papilloma. I don't know why the cores are also still inside. Collagenous ferrulosis. You remember collagenous ferrulosis?
Mm, it's, it's a tumor-like lesion. But I don't think it's a real tumor.
They usually look like this size, without creepy forming. And inside they have this basement membrane-like material with a brown cuticle surrounding it. And way to differentiate it, collagenous ferrulosis. When you do this is a tree, I think this is will be positive around the true cells. We did it some time ago. Do you remember?
Yeah, I don't know that it's
Let me show you, I'll show you some very quick pictures about collagenous ferrulosis. It's not going to take time. You just refresh your memory quickly. Collagenous ferrulosis. When we first look,
okay.
they look like this size. But look at this basement membrane-like material inside. They look like
Mm.
secretions. And then around it, you see this cuticle, black, brown
Yeah,
cuticle.
vertical. Yeah.
They have both, they have what they call true lamina and pseudo lamina. The true lamina are these ones that are more longer, that have undulating surfaces, or what they call, what do they call it? But that the first lamina will have roundish. This is first lamina, very round cuticle. These two lamina, you see this having this undulation. We call this Baker blebs. You see these blebs.
Mm.
These are luminal cells. But as this one surrounding the first cuticle are myopithelial cells. So this will be P63 positive, but the lumina will be P63 negative. Collagenous cellulosis.
Luminous cells, abi?
Luminal cells surround the true lamina, while myopithelial cells surround the false lamina.
Is it lamina or lumina? It's lumina now.
While luminal cells, yes, the lumina, you're right. Pseudolumina and true lumina. So lumina. So this is pseudolumina. Lumina. You can see the cortical surrounding it. In the basement membrane-like material. You can see the myopithelial cells are the ones surrounding the pseudolamina. Lumina, sorry. P63. Look at the true lumina. It has no myopithelial cells staining, no P63 staining, but you can see the apical blebs. Or this, there's a name they used to call these things in hobnailing. Okay. That's all for now. So that brings us to
So the most important thing we should remember is in this question, is the myopithelial cells tailing pattern in papillary lesions of the breast.
mhm.
That's what we should go away with.
Can you go through them?
Hmm?
Review them.
Okay. In papillomas, in intraductal papilloma, the periphery of the lesions and the core, that is the fibrovascular core, both stain positive for myoepithelial cells.
Mhm.
Then DCIS in papillary, well, sorry now, DCIS in intraductal papilloma,
Mm-hmm.
you will have the periphery being positive and then the core so being negative. So there's no myopicilla cells in the core.
Again.
I said DCIS in intraductal papilloma.
Okay.
The the periphery is positive, like you have in ordinary benign intraductal papilloma. But
Mm-hmm.
the core, the center is negative because of absent myoepithelial cells.
Mm-hmm.
Then the third category is encapsulated uh, papillary carcinoma and
Mm-hmm.
invasive papillary carcinoma.
Mm-hmm.
Myoepithelial cells is absent both in the center and in the periphery. So
Mm-hmm.
more or less we have like three categories, if I can remember,
Encapsulated papillary carcinoma. Okay, good. So,
in papillary lesions of the breast.
okay.
So the first category is the normal, in which it is biopsy is present in both center and periphery. That's the first category. Present center, present periphery, both. That's first, and that is the intraductal papilloma. The
Mm-hmm.
second category is myoepithelial cell P63 or whatever, is present only in the periphery
Mm-hmm.
but absent in the center. That's the second category.
Mm-hmm.
Then the third category are the cancers, in
Yeah.
which case it is absent both center and in the core and in the periphery. That is in encapsulated papillary carcinoma, and in faces it is absent in both.
My Yes, perfect. Images, so remember
Okay.
this video we once saw? We're not watching the video. Remember the video we saw this some time ago?
Yeah. Let me see. Papilloma present in cause and periphery involving a papilloma, yes. Presence in core, absent in periphery. Sorry, present in periphery. Oh, okay. I think I missed this second category. I mean another category. Presence in core.
In your category, sometimes there may be a small DCIs inside a large papilloma.
Okay, okay. That's the one I missed.
This DCIs will still be like DCIs inside here. So no, when you do staining, the rest of the papilloma will stain except the DCIs area.
Hmm.
But you are correct in the rest.
Hmm.
What other thing can you find in the encapsulated papillary carcinoma?
You have a capsule now, and the lesion is inside it.
Thick fibrous capsule.
Yeah, fiber capsule.
Mhm. Can you read through this one?
Which one? The one we highlighted?
No, no. I'm eating now. Can you read eating punch?
Okay, the teaching point.
Mhm.
The role of myopia immunostain in breast pathology, diagnostic utility of myopithelial cell immunostains. Immunostains distinguish benign from malignant breast lesion, present in normal duct or lobus, and benign proliferation absent in invasive carcinoma, used to highlight myopithelial cells and resolve key diagnostic dilemmas. So you have the various options: nuclear, cytoplasmic, and membranous. Then importance of using a panel of marker. No single stain is perfect. So you could combine them. Combine staining specifically with capolin or smooth muscle
In my program, I will
myopathy.
do this is just much hypnosis.
Okay. So key differential diagnosis where immunostains, myopathy stains are crucial. So you have pseudo-invasive as well invasive lesions. Pseudo-invasive lesions, adenosis, myopathy, yes. Okay.
Mm.
Sclerosis adenosis. In
Mm.
sclerosis adenosis, it may formerly look as though it is cancerous, but
Yes.
myopathy cell is present.
Yes.
Radial scar, yes. Microdiagnosis, no. So papillary lesions, intraductal papilloma present at periphery and in papillae. Intraductal papillary carcinoma present at periphery, absent in papillae. Why are they talking about interpersonal papillary carcinoma? It should be absent now in both.
What?
That look at this B. Interductal papillary carcinoma.
Another name for it is capillary carcinoma insights or something like that. I think to no, no, so let me see. What's the problem with
Why
that?
is it? They say it is
Papillary DCIS, that's another name for it. Papillary DCIS.
okay. Let me see the name there. Intraductal papillary carcinoma.
See it to a doctor. It has not spread. It's not invasive.
Okay, okay. So it's at the periphery only, absent in papilla.
Listen to
Encapsulated, yes.
the three division you gave at first.
The three division I gave, it's more or less like the three division now.
Yes, yes.
Yeah.
Yeah.
But then there is now a fourth division that they talk about.
That they talk about it here. That one's like for higher level guys. Come on, I'm coming. That one is just to warn you that sometimes this CIS may exist in a very large papilloma. If you do staining, you may see there are some areas in the large papilloma that may look monotonous, monoclonal proliferation. If
Mm,
or if you may see that you will see this as inside the large papilloma. Don't just because the papilloma is large, you just skip over it. I do that a lot. I just see a large papilloma, I just keep the papilloma. It's a benign. Look very well at the detailed architecture, the cytology again, so that it just wants you to look for possibility of DCIs inside the papilloma. I'm coming, please.
is particularly powerful when papilla lack a clear myopathy layer on H and E. Then core needle biopsy pitfall. Let's do this. Let's do like this one. In a small sample show core needle biopsy, papillary lesion with absent epithelium may be indistinguishable from invasive carcinoma. So papillary lesion with absent epithelium like was intraductal papillary carcinoma or encapsulated papillary carcinoma may be indistinguishable from invasive
Okay.
carcinoma.
I,
If
I, 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 I went out. I thought I was came back. So explain what you are saying.
I said there are some pitfall
Yes.
in core needle biopsy.
Mm-hmm.
So in those small biopsy,
Mm-hmm.
papillary lesion with absent epithelium such as intraductal papillary carcinoma
Mm-hmm.
or encapsulated papillary carcinoma may be indistinguishable from invasive carcinoma.
Mm-hmm.
So if architecture suggests a papillary lesions and no epithelial cells are found, the preferred approach is a descriptive diagnosis. Fragment e.g. fragment of papillary carcinoma, distinction between invasive and in situ to be made on excision.
Mm. Okay, if you take a biopsy, just see papillary lesions without the epithelial cells. We cannot say if it is a if it is a
Invasive.
papillary DCIS that you didn't get to the base, or encapsulated papillary carcinoma or invasive. You're right. It may be difficult, right?
Yes.
Hmm. You need to avoid overdiagnosing invasion. Hmm.
Mm.
Okay. We've talked about renal cell tumor. And some DCIs have attenuated myopithelium, but at least there'll be some nice staining. Don't expect that some all these cells will light up like Christmas trees. Some will just scatter staining around the myopithelial area. Okay, we are finally done with this question. Did it take us up to 1 hour, 2 hours? No, thank God.
Almost. Like 1 hour 30 minutes.
But at least we were able to refresh our memory and understand this concept better, right?
Yeah, you touch a number of things.
Yeah, one day my wife saw me, I was reading something. He came back after some hours, 2 or 3 hours, I don't know. That come you're the only one question in 2 or 3 hours. I told her in these 2 or 3 hours, I actually looked at 10 diseases. Okay, so go on a short break and come back. What do you think?
Yeah, yeah. How long should we spend?
Tell me, how long do you want?
Let's make 15 minutes.
15. Okay. Is that not too long? Okay. Let's make it 15 minutes.
Okay. Well, if within 10 to 15 minutes, so I can come back in 10 minutes.
Uh,
So I'll leave my audio
let,
on.
let's start on the 20th minutes mark.
Okay, 1820. Sorry.
Yes. Okay. Thank you.
But it's okay.
Okay.
Brother?
Hello, are you there?
Yeah.
We'll start shortly.
Okay. I also thought that, wow.
Hello, sir.
Yes.
Okay, I can start now. So, next question.
Hello, the following. I would take E.
A.
E.
Okay. I'll take B. Let's see. I'm correct.
Okay.
Unilateral
You are correct.
physiologic. You understand? Unilateral cannot be physiologic because the physiologic will most likely be bilateral.
Okay, okay.
Percentages, I'm not sure, but a lot of times I just take a guess.
I'm also not sure.
So let's take B. Let's see. And we're right.
Okay. You are right. You are the one right.
Okay. So let's look at This one won't take time. We're not good. They're not an extensive something here. This one won't take time, so don't fear. At least brother has come with his multiple panels. Okay,
Mm-hmm.
so look at the details. So bloody nipple discharge is most commonly associated with papilloma and hyperplasia. The answer is true. Intraductal papilloma is the most common benign cause of bloody nipple discharge. Papillary lesions often cause hemorrhage within the duct, especially when they are large, central, or undergo infarction.
Mm-hmm.
Ductal hyperplasia, while not classically a major cause of bloody discharge, can be associated due to epithelial fragility and increased vascularity. So sometimes you're going to have UDH, maybe that will feel huge, goes infarction and it sloughs off or something like that, maybe. Then spontaneous nipple discharge is most often physiologic if it is unilateral and occurs from a single breast duct. No. Physiologic benign discharge is typically bilateral. It's non-spontaneous. That's another thing. What do you mean of non-spontaneous?
It occurs with the it does not specific, that means it doesn't occur on its own. You have to
Manipulate it, right?
manipulate it.
Yes, and then it can arise from multiple ducts because it's going to be widespread. And no, it's not going to be, going to be non-bloody, right? It's not going to be bloody. And it's going to be milky, greenish, clear, like breast milk. In contrast, spontaneous unilateral single duct discharge is a classic presentation of a pathologic process, such as papilloma can do it, but not only papilloma. B-cells can do it. Invasive cancer can do it. Ductoptasia, where you have extrinsic duct, like duct, can do it also. Bloody nipple discharge is not more common in patients with malignancy than in patients with
Mm-hmm.
breast tumors.
Yeah, that's true.
So why bloody discharge is suspicion? In most cases, it is caused by benign conditions such as papillomas, ductoptasia. Although malignancies like this, Asperger disease can cause bloody discharge, statistically benign etiologies are more common. Studies show that only 5 to 50% of patients presenting with bloody nipple discharge are found to have carcinoma. Only 5 to 50% of those who present with it have carcinoma. Florid papillomatosis of the nipple and Paget disease to be associated with bloody nipple discharge, yes. Both conditions involve proliferative or neoplastic processes in or near the nipple duct, increasing the likelihood of nipple discharge. How does florid papillomatosis of the nipple appear? You know about it? Let's see if we can track one and see. Florid papillomatosis of nipple. No, nothing like that. And I can look at here. Let's just leave it because I think it's actually with papillomas and I don't know. Papillomatosis, Paget disease is often associated with underlying DCIS or invasive carcinoma and may present with crusting, erythema, erosion, or bloody discharge. Florid papillomatosis is a variant of multiple intraductal papilloma. Yes, a variant of it. Maybe that here, florid papillomatosis just means intraductal papilloma that is multiple. Normally, it should
Yeah.
be one duct. When you now find it multiple duct, that become florid papillomatosis. Okay. Number 5. Spontaneous nipple discharge is associated with carcinoma in situ in approximately 8% of patients. While most nipple discharges are benign, spontaneous discharge, especially if unilateral and bloody, does carry a risk. The likelihood of cancer is 5 to 15%, they told us here. Here they say 7 to 10% overall, depending on age and clinical context. Higher in older women, especially if associated with the palpable mass. Okay. These teaching points quickly and we are done. The last case, we didn't even review questions.
It's okay.
Okay, no problem. Okay. Okay, let's run this. Good. Let's leave it. This thing around with block questions. Spontaneous nipple discharge is relatively common symptom in 7% of patients presenting with breast-related complaints. It's not a sign of malignancy. It can be benign or physiologic process. Physiologic process is going to be bilateral involvement, yes, multiple duct, and non-spontaneous. And the appearance will be milky, clear, whitish, or greenish. What are the common causes of physiologic discharge? Common causes of physiologic discharge.
Hormonal, like pregnancy, lactation, endocrinopathy, like hyperparathyroidism, medications, antipsychotics, antidepressant, spirolytron too, nipple stimulation or trauma.
Okay. Pathologic discharge is going to be spontaneous, without manipulation, unilateral, single duct, bloody sanguineous or persistent, palpable mass on imaging, microcalcification, ductal abnormalities, warranting workup. The causes, the benign causes, the most common benign cause is benign, which is ductal papilloma, often in a central large duct or peripheral small duct. It will undergo erosion, infarction, and lead to bleeding. Ductal hyperplasia can also cause it. Ductal ectasia and with chronic inflammation can cause it. Malignant causes are this here is probably disease of nipple. Only 8% of patients with spontaneous nipple discharge are found to have malignancy. Mammography is the first line, people over 30 years. Why don't you do mammography in people less than 30 years?
The breast density,
Breast density. What's the mammography screening algorithm for the United States? Do you know?
what?
Mammography guidelines for United States.
I don't know.
Do you know for UK?
It's still the age that for younger women, I think it should be less than 40 in the UK. Less than 40. Sorry, over 40 use mammography, less than 40 use ultrasound.
Wow. Oh, okay. Let me do something. I don't know why I refuse to help me. Let me see. Let me see if you can help out. Okay. Mammography guidelines in the United States. So 2025, the US Preventive Services Task Force say start at the age of 40. But somebody with 30 can only do it because the person has symptoms already, right?
Maybe.
Yes, every 2 years, age 40, every 2 years. So we don't want to do it until a woman has finished giving birth. By 40, a lot of women have finished giving birth, true or false?
Right,
True.
so that one is relative.
Yes, into our next years. The age is age 74. But people who married early would have stopped giving birth. The end age is age 74. The US Preventive Task Force, age 50. They recommended age 50, but lower the age due to rising breast cancer rates among women in their 40s, which have increased by 2% since 2015. So 40 to 74. That's American Society, Cancer Society is annual 40 to 44. Ages 55 to 45 to 54. Okay, the age of onset is 40 to 44. maximum of 44. Then annual screening until 54. Then after 50, from 55, biennial. What do you mean of biennial?
Is this I
What do you mean of biennial?
twice in a year?
No, every 2 years.
Not, are you sure it's every 2 years? It's twice in a year.
No, no, no. Let's check the meaning of biennial.
Okay.
English language students. So let me see. I'm going to wait to pull this away. Oh, perfect. Mhm. Biennial meaning biennial, sorry,
Biennial.
taking place every other year.
Okay.
Biannual,
So
let's say
that's
biannual.
okay, okay, yeah. Every 2 years. All right.
Biannual. Occurring twice a year. Biannual is twice a year. Biennial, every 2 years. I think I've seen
Exactly.
something like that in my program. Your program director or something talked about it before. I was arguing, almost arguing to you like you. I was like, biennial should be twice a year. So just say 40 to 74. We don't need all these things. Different people, but 40 is everybody says. High risk people, you will do annual with MRI from 25. Anyway, that's just it. I'll wait it.
How many are you set? You are in PGY2 now, right?
Yes, going to PGY3 by July.
How many are you in PGY2 in your program?
Right now, PGY2. We are
Mm.
only two. Why are you laughing?
No, you are not many.
Are you more than us in Nigeria? How many years is residency in pathology in Nigeria?
This guy no
Well, minimum four.
Mm.
Minimum. Even
How-
four, most people finish like five.
4 years,
But
right?
yeah, minimum.
But it's
Wow.
different.
So what makes you finish
No,
earlier?
I mean how the bed is. This one, you enter one place.
Well, I mean of you. So what makes a man finish earlier than other? Another 4, 5, and that person finish at 4.
It depends on exams are two phases. It depends on when you write the exam. Some people may not write the exam, the first exam until after 3 years in the program. You can't write the exam earlier than 2 years, but some people might even not write it until
What is
3 years.
so how long can the person stay if the person doesn't pass the exam?
No, that is first part. We have part one, part two.
Oh, part one is
So
only minimum of 4 years.
no, minimum is 2 years, but there may be various factors depending on where you are doing the program, depending on if there are strike action, depending on the number of things. So you could have some people writing the first exam after 3 years. My first exam is after 3 years.
So if the person doesn't pass the first exam, the person
Okay,
will
so it's around in the third year, rather, the 3 years.
not. Okay.
So it now depends on whether you pass that first at first instance. Then if you now pass it, you now still have like 2 to 3 years to do the second part. You understand?
Mhm.
So at the end of the day, it could take between 4 to 6 years or some a little bit more than six. But after 6 years, if somebody did not finish, it's going to be like probation more or less. They can get extend for like 6 months, 6 months.
Every 6 months, right?
Mm.
I mean, you keep writing exam every 6 months. Hello?
Hello?
I mean, the person
I
keep
said
writing. The person
the
keep writing
yeah,
exam.
the exam
Yeah.
is twice in a year.
Oh, wow.
So,
It's well, oh. I can't hear you, Shawel, but it's well. Anyway, thank God that. So can you go back and finish if you want to finish? Let's say you
eh,
want to write the exam. Can you go and write it to West Africa and just get it without doing any additional residency there?
well, I'm not so sure now. It is possible, But for me, I've already resigned this, so I'm not going back.
Wants to bridge. So let's study hard and clear the UK pathway. After I can go back and easily write part two. With your UK certification or US, you can write part two now in Nigeria. We don't need to.
Well, it depends. Some I'm not so sure, sir. I don't know. Let's say it goes.
I can employ you without writing part two. Let's hope so. But that's if you at all you want to be like a visiting prof. Anyway, that's it for this case. So let's do the teaching point. We are done with this. Histology. Okay, we are done. Okay, we talk about 40 years. When did we stop? When did you say 40? So good. Mammography after 30. Ultrasound is for younger women who have dense breasts. It helps in the
Who have
trajectory.
what?
Hmm? Hello? Hello, evening. Hello? Hello?
Hello, Jonah.
I'm listening, yes.
You are saying something?
Ultrasound is for younger women who have dense breasts, right? And help to
Yeah.
detect tracheal papilloma or complex cystic lesion. So tracheal papilloma is detected not through mammography, but ultrasound. MRI is very sensitive to detect small papillomas and non-mass enhancing patterns. Cytology is very limited. So we
Hmm.
can look at different histomorphology pumps. Let's look at, I think we already done this, right? Let me see. Yes. Let's quickly get MCQ questions, please. What's happening here then? Doing coding for me. Okay, let's peep into the next question. Okay. Be fast. Okay. I'm going to create a new platform soon.
Jonah,
Hmm?
your ChatGPT prompts. Did you just formulate everything on your own, or you maybe you learned something, had a learned something in addition to your intuition? You learned some
Most of
prompt
what I
somewhere.
know from ChatGPT is from using it. Although I got some of my, I to some people too. Whatever skills they learned, they showed me too. I didn't really do any formal training on ChatGPT.
Okay.
But the thing is, it's like mobile phone. The more you use it, and there are many functions, all these things. There are many, all these, I know what all these tools are. The more you use it, and ChatGPT is so good that you can actually ask it question on how to use it. Whatever you want, it's going, we're going to develop it based on that. Perfect. The one we had before was already so full, so it was finding difficult to operate. Let me rename this. All these things is exploration. Like my son now is 3, but he taught me some things on laptop that I never knew as an adult because he explores a lot. I give him he used the laptop to do some of his school and other things. He was one that taught me that if you have YouTube, I don't know if I've told you before, you have YouTube playing and you want to go back to the beginning, just press 0 on the keyboard to go back to the beginning. If you want to go back to the middle, press 5, 50% time. 9 stand for 90% time. I never knew that before. A 45-year-old woman, okay, let's question number 1. Are you there?
Yeah, I'm there.
Question number 41.
What is the likely diagnosis? So it's pathological. And okay, hyperplatinum.
It's not, it's physiologic
Okay, physiologic.
because it's bilateral and non-spontaneous, right?
Okay,
There's a pathology in the brain, but in terms of the breast, it's from prolactin stimulating, it's physiologic process of prolactin stimulating the breast. You know, what
okay.
will hyperprolactinemia cause in real life? What syndrome?
Essence prolactin, huh?
Because what?
It stimulates the
Galactorrhea amenorrhea syndrome.
okay.
It's by blocking GnRH. GnRH, prolactin feedback, negative feedback is a prolactin is also anti. So it blocks GnRH, I think so. So FSH and FH not released, so there will be no stimulation of the gonads. That would cause amenorrhea. Galactorrhea because it directly works on the breast. Okay. And then antidopaminergic drugs, antipsychotics actually increase prolactin levels, something like that. In a way, I think yes. So they also call galactorrhea amenorrhea syndrome because dopamine is a prolactin inhibiting factor. When you use dopamine, prolactin starts acting much, stimulating the breast, causing galactorrhea, and then since prolactin inhibits GnRH, leading to amenorrhea. So it causes galactorrhea amenorrhea syndrome. Which of the following features is most concerning for pathologic nipple discharge? Are you there?
Yes.
What happened now?
What?
You are not that fast. Which of the following
No,
features is
my son came to talk to me, so I don't want to.
uh,
What is the
give
then?
me
Which
over to
question
you.
I will now?
Which of the following feature is most concerning for pathologic nipple discharge?
Hold on, please. Which of the following features unilateral and spontaneous?
Yeah, lateral and spontaneous.
That's pathologic.
Yes. What is the most common benign cause of bloody nipple discharge?
What's the most common benign cause of bloody discharge? Is intraductal papilloma, right? Yeah.
The 50-year-old woman presents with bloody nipple discharge. Imaging reveals microcalcification. What diagnosis should be strongly considered?
Ductal carcinoma in situ.
Yes, it may be papilloma with DCIs inside because of the calcification. Take note, and it's her age also. The patient presents with nipple eczema-like changes and bloody discharge. What is the most likely diagnosis?
Figure disease of the nipple.
What percentage of patients with spontaneous nipple discharge are ultimately diagnosed with carcinoma?
This one is crowning, 8%.
Yes. Which histologic pattern is most commonly seen in lesions associated with bloody nipple discharge?
Papillary architecture.
Which of the following is true regarding physiologic nipple discharge?
So, there is first line. 35-year-old with postinus.
No,
Okay,
but
it got this.
which of the following is true regarding physiologic nipple discharge?
Okay, okay. They appear milky green or greenish.
Which imaging modality is first line in 35-year-old with spontaneous nipple discharge?
Because it's symptomatic, I think.
Yeah,
Mammography.
mammography, that's first line. Which condition may cause greenish nipple discharge with chronic inflammation?
Doctor Tisha.
Yeah, cytology of nipple discharge is what?
It's often non-diagnostic and requires correlation.
Yeah, because sometimes you just see only blood. So I'm going to say there's nothing there. Okay, the following is true of encapsulated papillary carcinoma.
Associated with what?
Fibrobasculature
Fibril vasculature.
that can lead to bloody discharge. What is the diagnostic utility of ultrasound in evaluating nipple discharge?
Evaluating duct and papillomas.
Which of the following is not characteristic of pathologic nipple discharge?
Pathological multiple ducts.
Usually one duct that is poor pathologic. Solid papillary
Mm.
carcinoma is most likely to show which of the following features.
Papillary forms and potential bleeding.
Yes, okay. Mm. Next question.
Okay. How about the following statement? The judging children practice actually yourself. I seen for that.
I'll go for C. Okay, no, I will not. I will not. Let me see.
Of the time you are talking concerning issue and the contact.
I'll go for D. Oh God.
Mm. So, okay, I'll agree with you.
Hmm? What is it?
So, ethic and also,
You look so are you there?
take a D. I think it's a
You go for D, right?
D.
Okay. Let's try and finish this breast pathology today. You have Bible study today?
Yeah, everybody.
No? I don't know why it's not responding. That was what I choose before.
Which one?
Not what I
Anterior
chose before. I
anterior.
chose C before. I felt they just this significant that I felt that actually necrosis and significant right pillar are not seen. So sometimes some of these benign lesions may have areas of necrosis and significant atypia. Anyway, let's see. We may not even be correct, but let's see. Oh, they are right. Mr. Chat is right. So this is juvenile papillomatosis.
You can find it in that in an anterior. You see you find that.
I didn't get you.
Let's revise it in the material.
The material already has only three lines. But okay, we can revise it. Three images. Here is the image material. Let me revise it. And well, let me see expert parts. Juvenile papillomatosis. But this is Dr. David Hicks. Let me see who he is. He's very good in breast. I've seen some of his works, like in this same thing. That's of Rochester, New York. Sometimes you even, there are so many topics. Sometimes you have to go with the person you like best. David Hicks is here also. Juvenile papillomatosis. Let me see. How many pictures does he have? Oh, museum here. People choose it. Let me see this guy, juvenile papillomatosis. There's no need. Let's just go with this. They don't have much picture. I don't know why. Maybe it's not that common. I'll be so happy if we can finish this thing today. So let's start with, by the way, before we start with, before we look at the growth and the microscopy, what is juvenile papillomatosis?
Mm, okay, I'm not familiar with this.
Your voice is so low. I can't even hear you.
So I'm not familiar with it, but the explanation were is a benign progressive breast disease,
Mhm.
numerous cysts, small cysts,
Oh, Swiss cheese disease.
cyst disease.
Mm. So it's one is a rare disease. That's why I see ultrasound already can diagnose it. A firm palpable circumscribed mobile mass like fibroadenoma. Not like no, it's like fibroadenoma. And then when you look at it, you see multiple clustered cysts. So it's clearly seen on ultrasound examination. What is Swiss cheese?
And because of the appearance, maybe cystic, soft.
Have you seen Swiss cheese before?
I know cheese, whether cyst or not. I know it's going to be
I,
soft. Then
I don't think all cheese look like the same. So I mean, look the same.
yes. But normally cheese will be soft, but you could have some
Not
that
soft. I mean
maybe
the holes. This
hmm?
is example of Swiss cheese from Switzerland. The cheese of the Swiss. Switzerland
they
cheese.
make they make holes in it or what?
Yeah, look at it now. They make holes in it. That's what they call it Swiss cheese appearance. This is Swiss from Switzerland. They have holes in their cheese, not like us. They do not have. Look at this Swiss cheese. Yeah, exactly. See, this is multiple Swiss cheese appearance. Perfect. This is Swiss cheese. So you see, on ultrasound already, you can almost diagnose it. That this Swiss cheese appearance, multiple cysts. So it's typically found in children, adolescents, and young adults, but it can occur in elderly patients. It's called Swiss cheese disease because on gross you can actually see numerous small cysts. Look at the gross.
Hmm.
Swiss cheese derives from juvenile papillomatosis from the presence of numerous cysts differing in size within a circumscribed area. So the area of the mass will have cheese different in size. Yeah, some are large, some are small. So that's how Swiss cheese is, Swiss cheese appearance. It occurs in less than 1% of all excised breast masses. Juvenile papillomatosis does not equate the presence of papillomas in isolation. For the word papillomatosis does not automatically mean papilloma. Let me get a sweater for me, please.
Can any water be pure? Can anyone born of a woman be just? Look, God doesn't even trust his evil. Even the heavens are not absolutely pure in his sight. How much less pure is a corrupt and sinful person with the thirst for wickedness? If you listen, I will show you. I will answer you from my own experience, and it is confirmed by the report of the right people. Increase the heat and I replace the clothes.
Don't hear the seventh already. Sorry. It was cold. How to go and put on my jacket. Wait, Kwachi on my bed. Who you
Getting
there?
summer here.
If you listen, I will
Sir?
I said we're in summer in this place.
We are still in spring. The time is cold. Wow, that's good. So when does summer start in your area?
Well, normally it should just be starting around this time, but this one started maybe April, just little by okay, yeah, late April, sha.
Wow, that's nice. Wow. Okay. Juvenile papillomatosis does not equate the presence of papillomas in isolation, identified by grossly identifiable mass with multiple etiologic features. Etiology and pathogenesis, molecular genetics, PIK3CA mutations in approximately 50%, and AKT1 mutation in 20% are being reported. PIK3, AKT pathway, is involved. It's associated with 20% of females with juvenile papillomatosis have a family history of breast cancer, typically involving first or second degree relatives, mothers, and maternal aunts. Rarely linked to hereditary tumor syndromes, especially in males such as neurofibromatosis type 1, Noonan syndrome, Cowden syndrome, Proteus syndrome. Sorry, my baby is crying. I'll pick him up. Just 1 minute.
about the houses that are ready to come down. Their riches will not last, and their wealth will not endure. Their possession will no longer spread across the horizon. They will not escape the darkness. The burning sun.
Okay, so the mean age of diagnosis is 26 years, and it can range from 7 months to 81 years. So all the other people can have this actually. 70% are diagnosed before 26, both males and females. Palpable mobile circumscribed mass, bilateral multifocal, mesenchymal fibroadenoma, older age. So 3 to 10% may develop cancer if there is family history of breast cancer, older age and diagnosis, bilateral multifocal disease, recurrent lesions. It's a benign lesion. I should undergo clinical follow-up. Mammography, circumscribed mass, like fibroadenoma, microcalcification, ultrasound will show internal spaces, pathology with numerous cysts that are 1 to 2 millimeters, reported Swiss tooth appearance, microscopy. Now, let me do microscopy. So in microscopy, we see cysts associated with juvenile papillomatosis They have distinctive appearance on imaging and gross appearance. The cysts contribute to the size of the palpable mass. They are often filled with histiocytes. So, juvenile papillomatosis is characterized by multiple cysts of varying sizes, forming a discrete mass in a young man or woman. Additionally, typical features are florid epithelial hyperplasia. Florid epithelial hyperplasia. And papillomas. So that means the reason why they call papillomatosis is that there's some areas that will show papillomas.
Yeah. Sorry, let me look at it again. What's the microscopy again? Yeah, cysts,
They have
pleuroepithelial hyperplasia,
yes, and areas they show papillomas. Like here, you can see this papilloma here. You understand? So
necrosis, papillomas.
you can
So,
compare with other tumors too. Lobular carcinoma, invasive cancer, vegetative carcinoma. Okay, so let's quickly go back and expand on them. What? Okay, good. So let's quickly review this.
Oluwa.
Let's review this quickly and then we are done with this topic. This is not a hard topic. At least we know. Let's see.
Last time we read the Messiah is born.
Juvenile papillomatosis. So can you read through this?
Okay. Papillomas is a localized mass-forming lesion of the breast, affecting children, adolescents, and young adults. Histologically represents a proliferative cystic disease comprising a constellation of benign disease within a circumscribed benign changes within a circumscribed area. So we've seen those benign changes. We have cysts, epithelial hyperplasia, apocrine intraductal histiocytes with chronic changes, secondary stromal fibrosis or scarring. We could also have necrosis. I think we mentioned that, and even the ATP too. It is compared to typical arterial parasites that creeping some micropyral figure seen in 40% of cases. Comedoid type necrosis, 15% of cases. Significant intraductal ETS is present in greater than 30%, 33%, raising concern for increased neoplastic potential. Differential diagnosis, avoiding misinformation. Do not confuse with intraductal papilloma. Okay, why? Benign lesion arising from a single dot, often with central fibroblastic core, and not necessarily part of a grossly circumscribed mass.
Yeah.
Don't confuse with it.
Juvenile papilloma will be a gross mass. Juvenile papillomatosis will be a mass with switch appearance. Papilloma may just be a benign lesion from a single dot. Sometimes you never even see it macroscopically.
Yeah. Mimic carcinoma, radial scar may mimic carcinoma histologically, but lacks the mass-forming cyst-rich character of juvenile papillomatosis. Cysts alone or sclerosing hydrosis may show overlapping changes but do not constitute juvenile papillomatosis unless part of a localized mass with associated hyperplasia. Key diagnostic criteria for JP, what it is, that is features above within a discrete palpable grossly visible mass, especially in a young patient. JP and breast carcinoma risk. Approximately 10 to 15% of patients develop breast carcinoma. Importantly, most cases of carcinoma occur in patients with a strong family history, particularly involving maternal relatives. Carcinoma in JP patients is more frequently observed at the older end of the JP age spectrum. Documented associated malignancy include gallbladder carcinoma in situ, intraductal carcinoma, invasive biloblar carcinoma, secretory carcinoma, which is notable for its juvenile onset. That's the common carcinoma in young patients. Invasive carcinoma in young patients. This
Secondary carcinoma, right?
yes, secretory.
I've never forgotten secondary carcinoma even. We did this some time ago.
This reflects the need for clinical surveillance.
What's the hallmark of secondary carcinoma?
I know it's occurring in young patients. You could have ducts, maybe a typical duct that has secretions. I can't remember.
IHC.
IAC. Is it the one that access one?
Somebody is granular cell tumor. David Hicks.
Joseph is the husband of Mary and the father of.
Let's revise it quickly. Sorry. It's not bad to revise. Somebody sang a song. So remind me, dear Lord.
Number 3. Why they were in Bethlehem? The time came for Mary's baby to be born. Because all the
Look at this. So it's secondary carcinoma, multiple changes, multiple clusters or species filled with secretory material as circumscribed borders. In true lactational changes, the species appear empty. Secondary carcinoma, luminal secretory materials is prominent and also seen in cytoplasm in secondary carcinoma. The nuclear lining in the species are uniform and bland in appearance. Metastases are absent or rare.
Came to Mary to say,
It has ETV6 translocation. What other tumors have ETV6 translocation?
It is Joseph. Joseph is the father of Jesus. And
so what other tumors have ETV6 translocation?
Mary gave birth to Jesus in a place where they keep animals. Now see baby Jesus here. So Mary gave birth to Jesus in a place where they keep animals. Because
I can't remember the moment.
Only the
Which one?
House. So Jesus.
Do you remember, Jonah?
Now
I can't remember too. ETV6 translocation tumors.
Where was Jesus born doing? Jesus was born
infantile fibrosarcoma. I saw that TRK3. I saw it somewhere. In the whole soft
congenital
it depends on what is fusing with ETV6 with.
Jesus was
born, and there are so many
AML,
CML, ABL. There's this one, the one we are looking at, ATV6 is actually I don't know the future, let me see. Okay, with NTRK3. You find infantile fibrosarcoma. Let me see if there's anything important. NTRK3, S100 positive also. It's like A1 PCC3 positive. Let me see. It lacks my epithelial cells of A13. It's a difficult tumor anyway. See, granular cell tumor also appearing here. You also have luminal secretions. Let me see. Pan-TRK3, ATV6 fusion. Arsenic cell carcinoma will have basophilic granules in the cytoplasm. That's 100 positive. So in terms of it has this ETV6 and NRTK3 mutation. I think there are more tumors that have this ETV6, and
Fibrosarcoma too.
ER3, yes, fusion tumors. Because you see, molecular testing is now very important in pathology, much more than ever before. So you can 12-15. I'm telling you, you will meet it a lot. Infantile fibrosarcoma. In fact, that's what they use now. A lot of things, a lot of tumors are now classified in WHO based on molecular, no longer H&E and all those things. Secretory-based carcinoma, yes, congenital mesofibroblastic. Okay. So let's say histology. The main histology features is that it is a solid tumor with microcystic honeycomb appearance and tubular, often lobulated with fibrous strands. Cytoplasm bubbly or eosinophilic due to its secretory materials. Nuclear uniform with minimal pleomorphism, low mitosis. Secretions are PAS positive, Asian blue, mesocameral staining. PCIS can be common, RHC. Usually, remember we saw another basal-like carcinomas. It's a triple negative basal-like with good prognosis. Remember, sir?
Which one? Tubular?
Do you remember the carcinomas that were good prognosis for triple negative basal-like carcinomas?
Yeah, tubular.
Mhm.
Oh no, okay. Which one?
Secretory, tubular acinic carcinoma, adenosquamous, adenoglandular squamoglandular, something like that. Then the fibromatosis like breast cancer, basal like these cells have good prognosis. Secondary carcinoma is also has good prognosis, triple negative. So it's ERPRK2 new negative. So how do we now differentiate secondary carcinoma from the rest? It's S100 positive, but there's something that we used to differentiate it from basal-like cancers.
So you can make yourself 100 positive.
Yes?
I said secret carcinoma is 100 positive.
Yes. Yes. But remember when we talked about basal-like cancers, what are features of basal-like cancers?
And some of them are triple negative now.
Basal-like cancers are generally triple negative. And what other markers we use for basal-like cancers of the breast?
This one.
CK56 and
And they do some and what? EGFR.
Yes. CK56, EGFR, both positive in basal-like. And this tumor, cervical carcinoma, is CK56 EGFR positive, which places it alongside basal-like carcinomas. However, I see CD117 positive, and so the major thing is this ETV6 NTRK3 mutation, apart from the morphology. Ischemic apocrine, yes, We did this earlier on when we did basal-like carcinomas. So let's come back here. You can continue from here.
Okay. Necrosis in JP not always malignant, although it's often a red flag for malignancy. So comedy-like necrosis can appear in JP without carcinoma.
But the thing is this, even though it's a red flag malignancy, there's an important exception. JP serves as an important exception to this rule, where necrosis does not equal malignancy in juvenile papillomatosis.
Yeah. Similar person has seen some benign conditions, including infertile fibroadenoma, intraductal papilloma with floral aplasia, lactating adenoma, radial scar, inflammatory condition, floral papillomatosis of the nipple. Necrosis alone is not diagnostic of carcinoma. Architectural complexity, cytologic atypia, and associated stroma response are essential in determining whether necrosis signifies malignancy. So if the two are present, maybe, I think so, it could suggest malignancy. Clinical implications and management. JP mimics a fibromyalgia. If surgical excision is the treatment of choice, incomplete excision can lead to recurrence. Long-term follow-up is advisable, especially in patients with strong family history, bilateral of multifocal disease, histologic atypia, or necrosis.
Yeah.
So the take-home pairs, localized cystic lesion is hallmark of JP, apocrine metaplasia, etiologic necrosis, frequently seen but not malignant. Greater or equal to 10% of cases show necrosis. Benign necrosis, not equivalent to carcinoma. ATPR present in greater than 30%, requires caution in reporting. 10 to 15% risk of carcinoma. Most have positive family history. Secretive carcinoma reported association. Sorry, I didn't say it again. No. Secretive carcinoma has reported association in adolescence. Then differentiation from papilloma from what? For papilloma of radial scars. Florid, blood on gross. Sorry, based on gross and histologic integration.
Yeah.
So it has Swiss cheese pattern.
Yeah. On the both gross and the microscopy, you may see other additional patterns like papilloma-like pattern, hypocrine metaplasia, many things, but maybe it's typical in some places and necrosis. I'm almost done with this. Kingdom. What is this? Come. Die. Will be done on earth as it. What is the most defining histologic feature of juvenile papillomatosis? Yes.
The cystic disease. The proliferative cystic disease.
Epithelial proliferation, distinguishing of diffuse processes. Which of the following features is most commonly associated with Juvenile papillomatosis.
Multiple evidence, costly evidences with African metaplasia.
So it shows numerous cysts with different metaplasia, often with mass forming lesion. Which lesion must juvenile papillomatosis be carefully distinguished from due to overlapping features?
Sorry, which one?
What lesion they have to differentiate it from? They have similar features.
Okay. Introductory papilloma.
Yeah, but this one will be very cystic and multiple cysts and be a young person. Mass with Swiss cheese appearance. What percentage of juvenile papillomatosis show necrosis?
50%.
Which of the following etiologic features commonly found in juvenile papillomatosis, but it's not diagnosis of carcinoma?
Comedo-like necrosis.
Yeah, it will be necrosis. It does not mean tumor. Secondary carcinoma is most likely associated with juvenile papillomatosis in which demographic of patients? Number 7. Secondary carcinoma is associated with juvenile papillomatosis in what demography?
Adolescent patient.
What is the significance of finding apocrine metaplasia in juvenile papillomatosis?
Diagnosis of malignancy. Sorry. What is the signal finding apocrine metaplasia indices? Benign change commonly found is a benign change.
Yes. A benign change commonly found in juvenile papillomatosis. Juvenile papillomatosis will have apocrine metaplasia. What other benign changes? Introductory papilloma. What other benign changes? You saw it.
We have the common necrosis.
Yes. Florida papillacea, cascas, abscesses, Florida papillomatosis. Which feature distinguishes juvenile papillomatosis from a radial scar?
Glossy circumcised mass.
Remember that radial scar does not have a mass. No, it's not a mass forming lesion. There are mainly microscopic findings, maybe calcifications. Incidental, they don't have mass. So if it's a mass forming lesion, and they have multiple cysts, just like the juvenile papillomatosis. What's the most important histologic factor to assess when necrosis is seen in a breast lesion?
ATP, sorry, architectural and cytologic.
And cellular atypia. Which of the following may mimic comedo type BCIS, but it's not malignant?
Necrosis.
A breast lesion in 20-year-old shows cysts, papillary fronts, florid epithelial hyperplasia, and focal necrosis. What's the most likely diagnosis?
Juvenile papillomatosis.
Yes, so it's really a lot of cysts, papillary fronts. So sometimes what we will call genital papilloma, if it has a lot of cysts in it, maybe juvenile papillomatosis. What clinical impression might juvenile papillomatosis give a physical exam or imaging?
Followed by GPT.
What's described as a mimic impression. And intraductal papilloma is not usually a mass forming lesion a lot of times.
It's also okay. Well, mobile well circumcised mass, not frontal cysts.
Usually mimicking fibroadenoma. It's a mass forming.
It's not like that sweet cheese is fluctuant.
No.
Okay, that's the point to note.
You're imagining that it's fluctuant. It's not fluctuant, it's a fab mass. Which breast cancer subtype has been reported in association with juvenile papillomatosis?
Wait one. Which breast cancer substance have been associated? That's a good true, but what's the answer? Oh, there are more than one.
Invasive ductal carcinoma, invasive lobular
It's
carcinoma,
a
DCIS.
secret, yeah.
Which histologic finding is seen in isolation, insufficient for diagnosing carcinoma and juvenile papillomatosis?
Commado, focal choroidomyopathy.
Can we go on 15 minutes break?
It's okay.
Okay, no problem. I'll just rest a while. So we'll come back in the 45th minute, right? Hello?
Yeah.
You can use that time to rest a little bit so that we'll be more refreshed. You say you don't take coffee. You are taking coffee, prepare coffee. But since you don't take coffee, just rest a little while. We'll come back and resume in full swing in 15 minutes. Okay.
Hello, Jonah.
Sir?
Yeah, my wife wants to say hi to you.
Ah,
Uncle Jonah.
longest time.
No see, no ask.
Ah, how you
No,
doing?
yes.
But the person I asking for is not used to it.
How you doing?
I'm fine now.
I
How
heard
are you too?
you are now a nurse in United Kingdom.
I'm wanting to be in the USA as well. That's why I'm talking to you.
You want to come to the US?
I want to do my NCLEX by
Oh,
August.
my wife has a friend who wrote NCLEX and came to the US too.
That's even why
Wow.
I'm talking to you. Because,
Wow.
yeah, I want to write this about in 3 months' time. However, um, I would have loved to wait for my husband to support me.
Sorry. Okay, let's come back. Sorry, I went to ease myself. When it was time, I now had a running stomach.
Sorry.
I don't really want to
Hope you are better now.
Yeah, I'm better now. Not like running stomach. I just have to go to ease myself. Okay, look at this. Thank you so much. So let's go to the next question. My eyes are a little bit clear. I was feeling sleepy earlier on. Okay, let's answer this question.
So during science, we go cleaning the balloon. Right? Don't eat the balloon. Eat the balloon. Come.
The patient with undiagnosed.
Here, Bodabuli Jemachuku, sorry.
Oh, Uru.
What did we say was positive for beta catenin before? Do you remember?
Dinachi.
Granular sarcoma.
Yeah, was it last said tomorrow? I can't remember. Do you remember?
It's granular sarcoma.
Last said tomorrow. Oh.
Uru Dinachi, come here.
Into the following clinical presentation is most likely.
What tumor is this, by the way?
Uru Dinachi.
Is negative. Smooth muscle vaccine. Is a spindle cell tumor.
Yeah, spindle cell kind of tumor, right? Maybe sarcoma or something, I don't know.
So CD34 is vascular. Is not vascular. Is not epithelial. That's
It's not
pantocircular.
it's not this solitary fibrous tumor kind of thing. I try know those ones are negative for is it CD,
Which is not like it. It is issue of metaplasia on the right breast. Treated 1 year ago, primary excision and a 32-year woman with confirmed stellate mass and germinalization in the APC gene. 40-year-old with rapidly growing gender mass. A 60-year-old with well-described mobile palpable mass and gynecomastia. Well, the answer is B. Maybe fibromatosis. Stem stena, palm stellate mass. The answer is B. D is gynecomastia. D,
No,
gynecomastia.
I don't have going
E,
to
Yeah, it's not A is carcinoma, D is gynecomastia. Then C, probably growing tender mass. That could be anything.
Gynecomastia has APC gene mutation, is that what you're saying?
No, I'm saying the answer is B. B. I'm just
Yeah.
ruling out other ones.
Okay.
Ruling out the
I
other
will
one.
say, yes, you're right. It's either, I'll go with B too.
Maybe fibromatosis. Like a fibromatosis.
Look to me like it's sarcoma. You can say mitosis.
But it's not malignant.
Look at this
If
mitosis
it's
here. This looks to me malignant. You know, there's some
there
degree
could
of
be mitosis,
glioblastoma.
but it's not looking so
You know, there are some low grade sarcomas that don't make it really look like this.
Yeah, that's true, Sha.
Anyway, let's see. And what do I'll go with you. I'll go with you.
Is it fibromatosis?
And that is metaplastic carcinoma of the right breast. Metaplastic. That is also tempting. But it doesn't show radiation atypia. You understand? So I'll go with B. But let's see.
Oh, nodular fasciitis. Nodular fasciitis is stellate.
So histology, short fascicles of clot spindle epithelial cells with vesicular nuclei. These nuclei, yes, they are partly vesicular or kind of bubbly. Variable cellularity, scattered mitosis, loosely arranged myxoid background.
Which some people call what again? That loosely arranged myxoid is called what?
It's true. There's a name for it. It's called there's a popular name for it.
Did I mention it?
Yeah, I mentioned it.
Tissue culture.
Yeah, tissue culture appearance. Yeah, I remember.
Yeah.
Tissue culture
Oh,
appearance.
it's even there now. Yeah, it's even there. Yeah.
Tissue culture. Now, SMA positive indicates myofibroblastic differentiation, pancytokeratin, rural metaplastic carcinoma. So metaplastic carcinoma will be cytokeratin positive, right? Metaplastic carcinoma will be cytokeratin positive.
Yeah.
Solitary fibrous tumor and other CD4-34 spindle tumors will be CD4 negative, 34 negative. Rapid growth, firm tenderness. Wow. Anyway, it's an opportunity. I don't really know much about nodular fasciitis. It's an opportunity to review it right now.
SMA possible, but cytokeratin positive. That's metastatic carcinoma.
So let's see.
Carcinoma with mutation suggest fibromatosis, which is beaten. Nodular fasciitis. But fibromatosis come to my mind too. That's with APC. But what is the answer here?
Fibromatosis will be beta-catenin positive.
Okay, that is the one I said the answer. But this one is 20-year-old woman rapidly growing tender mass. Oh, I understand now.
Fibromatosis. I don't even know much. This is under soft tissue, right?
Yes.
I've not reviewed soft tissue.
But you know that there are other lesions that are not epithelial. So in the breast. So okay, I got it now. The one I mentioned. So that telemass is the one that is beta-catenin positive.
That's the fibromatosis, right?
Yes.
Anyway,
What did they write about it there?
Let's review it in details and everything in detail, and then we'll see what can be done. This teaching point is so short, so let me just add everything at once. It's useless to come back to it later. So at the end of this discussion, we should be able to know.
I think we should have a go for it. We should have a go like 45 minutes for one question so that within 1 hour 30 minutes we are doing two.
I don't know if that will work because remember that some questions we don't even spend up to 20 minutes. Some questions we spend more time. Like now, I don't even have much knowledge of fibromatosis and nodular fasciitis and all those things. So if we have to look at the photographs, look at the reviews, the mutations, that
Okay,
will take more time than we think. The most important thing is that we should be learning. I will say that, and then by the time we come back, and remember, this is will not stick the first time, but the second, third time, it starts becoming
okay. Let's go on then. Let's go. I just say that yeah, sometimes it could be longer than that, but we could
and
just have it.
sometimes even shorter, depending on like this last one. I don't think we spent much time. This last one? Juvenile papillomatosis. I don't think we spent much time. So some of them, like something that is extremely new, may take more time to me.
It's okay. Let's go on.
So look at spindle cell lesions of the breast. So mention all the spindle cell lesions of the breast that you know.
You could have nodular fasciitis,
Nodular
fibromatosis.
fasciitis, metaplastic carcinoma. But let's not mention that, but let's just add it for just completeness sake. Fibromatosis, myofibroblastoma. I've seen a case of myofibroblastoma before. Can you imagine? It didn't even come to my mind here. That's number 6. That's myofibroblastoma. 60-year-old man with well circumscribed mobile palpable mass and gynecomastia. Myofibroblastoma is usually CD34 positive. I've seen a classic case of myofibroblastoma before. Usually well circumscribed and CD34 positive, but it's really CD34 negative. Now roots out myofibroblastoma. So we see nodular fasciitis and all that. So let's look at it. So let's start with nodular fasciitis. What is nodular fasciitis? As a senior pathologist, if somebody comes to meet you and say, tell me all you know about nodular fasciitis.
Okay.
The spindle cell lesions of the breast is benign.
It can be found outside the breast too, but
Okay. Sorry, yeah. In this case, the spindle cells are arranged in the fascicles in a loose mixed stroma, giving the so-called tissue culture appearance.
okay.
And the gross appearance, that's one I don't remember. Fibrobel. It's self-limited. Fibroblasts and myofibroblasts. Yeah, USPC associated neoplasm.
Okay, let's start. So let's start with the general definitions. I'll just pretend as though I'm teaching a class. So pardon me. Good day, ladies and gentlemen. Today we'll be looking at the pathologic, the molecular and diagnostic significance of nodular fasciitis. What is nodular fasciitis? Is it benign? Is it tumor or non-tumor? Let me know. Is this a tumor or not?
Is a proliferation.
It's a mesenchymal proliferation composed of fibroblasts and myofibroblasts. What in myofibroblastoma? What is the hallmark of myofibroblastoma? What is the hallmark of myofibroblastoma?
Oh, my myofibroblastima. Oh, that was more positivity. ER positivity, PR positivity.
Wow, I think it's true. You're right. I read some. I think you're very, very right. But I think it's ERPR positive. I can't remember that one. Are you sure of that?
Yeah, yes, it's hormonal positivity.
Yes, and then it's hormonally positive, and also it's CD34 positive, right? Usually well circumscribed. Then you have myofibroblasts. I miss collagen, separated by collagen fibers. That's what I remember from my case. I wish I had.
What?
Can you see it? This is myofibroblastoma. Myofibroblast separated by collagen.
Okay.
Prominent nucleoli. Then estrogen receptor positive, desmin positive, CD34 is the hallmark. CD34
Okay.
positive, BCL2 positive. But this are the major thing. Actin, of course, actin will be positive. You know. So I've had a case. So it's myofibroblastoma. The myofibroblast, well circumscribed, separated by collagen in the breast. That'll be a myofibroblastoma. Okay, we'll still come back to it. That's just by the way. So it's both fibroblasts and myofibroblasts that mesenchymal proliferation. And it resembles a sarcoma, both clinically and histologically. It's common in soft tissues, other places, and it is rare in the breast.
What is this?
Sorry, my place here is also a classroom, so don't mind the background noise, I beg.
No problem.
Lymphomatous is rare in the breast, also called pseudosarcomatous fasciitis, no longer used. It's part of the USP6 associated neoplasm family. What are other tumors in the USP6 family?
Right.
I can't remember.
So what is it?
Let's see if we can find examples. USP6 is already expired.
No, from the second line from here. Okay.
Security carcinoma is the one that ETV6.
ATP6.
ETV6, right?
Yeah, I think that should be it. Yes, secondary carcinoma, right?
NTRK3.
ETV6 NTRK3, yes, secondary carcinoma, infantile fibrosarcoma, Abi.
Number 3.
Infantile fibrosarcoma, right? Right?
Yeah.
ATV6, ATV6, NTRK3 tumors.
So USPC, that's the one that has ABC,
Oh,
nodal fasciitis,
ABC, are you sure?
aneurysmal
ABC,
bone cyst,
yeah,
aneurysmal bone
aneurysmal bone
cyst.
cyst, yes. Aneurysmal bone cyst, usually cystic bones without my epithelium. Let me see a cut notes. There's under bones and soft tissue.
Isaac, way Daniel up.
You see, the G went down. Your own should go down.
ABC. You're right. Actually, I knew this, but the thing really of it occurred to me again. I used to know it very well. USP6. It's the same thing you know. When you now go to another new legion, you'll not forget the one. God have mercy. USP6. Aneurysmal bone cyst is actually a very popular one for this. Aneurysmal bone cyst. Aneurysmal bone cyst. Primary. So this is
Myositis
CDH11 USP6 fusion. See, that nodular fasciitis is going to be MYH9 USP6 gene fusion. Myositis sophisticaans also, fibrosous pseudotumor of the digit, cellular fibroma of tendon sheath. I know this too. But I don't know it has USP6. Cellular fibroma of tendon sheath. This pathology you have to practice for a while and see many cases to be able to become used to a lot of things. ETV6 mutations, of course, examples are infantile fibrosarcoma, secondary carcinoma of the breast, and secondary carcinoma of the salivary gland, congenital mesoblastic nephroma. Anyway, so USP6, but the USP6 of ABC is CDH1, CDH11. What other tumors have CDH? So sorry, it's IDH rather. IDH is L-chondromas and the rest.
Not doing alphabet. Past the
As
level.
well. I remember we saw CDH somewhere. It is well, nodular fasciitis, MYH9.
Then draw lines to match.
MYH9. So it belongs to the USP6 associated neoplasm family, MYH9. It's actually a transient neoplasia. That is a clonal proliferation that can regress spontaneously. So we can't really say it's a tumor. It's a transient neoplasia. So are you there?
Yeah.
So nodular fasciitis is a kind of transient neoplasia. Let's go to epidemiology and clinical presentation. What is the age at which people begin to develop nodular fasciitis?
What letter is missing here in kite? Letter.
So adults, typically young to middle age.
Adults, typically young to middle age adults.
Number 2.
What else? Gender.
Okay.
As what gender?
Number 2.
Female. Okay, both, but typically in women.
Adult, typically young to middle
So
age.
what letter is missing?
Then gender, female, typically.
Show me bad.
Incidence is rare and more common in the upper extremities, rare in the breast. If it's in the breast, it's going to be subcutaneous or near muscle
So
fascia.
what letter is missing?
So it's it's just the word fasciitis. So it's going to be near a muscular fascia. That means it's either superficial under the skin or deep underneath the fascia. Or something.
Line.
Presentation is rapidly growing, painful tender mass. Rapidly growing, painful tender mass. I used to think that all tender breast masses were may benign. So yes, this can be kind of benign, but this is transient neoplasia. This nodular fasciitis. It usually appears within 2 to 3 weeks. That's why it's rapidly growing. It's not a tender mass that's been there for months. Within 2 to 3 weeks, already painful, and often less than 3 centimeters in size. What is the molecular?
Outside the circle.
But what's the molecular?
Don't write it inside the circle. Outside.
My H9, MYH9 USPC.
Yes. MYH9 fusion with USP6 is the most common, 90%. USP6 is a protease, ubiquitin protease. You know the function of ubiquitin? Ubiquitin, I think ubiquitin is something that tags breakdown products in the cell and takes it to the peroxisome or proteasomes and degrades it. So ubiquitin tags things that need to be broken down in the body. So if ubiquitin is mutated, things will not be broken down. So it's going to be is ubiquitin. That US stands for ubiquitin. So it's involved in protein degradation, cell signaling, and inflammatory regulation. There's a USP6 group family of tumors. So I have to memorize all the USP6 family of tumors. ABC. What is the fusion in ABC?
What is this? Fox. Show me a fox.
Is this CDH1?
CDH11. Perfect.
Okay. 11 CDH1.
CDH11, CDH11 USP6 fusion.
Okay.
CDH11 USP6 fusion. CDH11 USP6 fusion is involved in protein degradation, cell signaling, and inflammatory regulation. Protein degradation, cell signaling, inflammatory regulation.
Okay.
So I have ABC, myasthenic ossificans, fibrosous pseudotumor, some fibromas of tendon sheets. So close your eyes and mention 5 tumors that are in the USP6 Gene family.
Right. Right. Good. Hog. Right. Good.
Miss, are you there?
Nodular fasciitis,
Yes.
myositis ossificans,
Yes.
aneurysmal bone cyst.
I use my bone cyst. Yes.
Then the other ones. Complete it for me.
Pseudotumor. Okay, some tendons of from tendons, from fibromas of tendon sheets. Then pseudotumor cerebri. Sorry, fibrosous pseudotumor.
Okay.
Pseudotumor. What is the fusion in aneurysmal bone cyst?
CDH11.
CDH11,
CDH11.
USP6. Good. Blood pure, USP6
The
overexpression
S and H sound.
distinguishes nodular fasciitis from most sarcomas and benign mimics.
Dead.
So this is it.
Yeah, right.
A lot of times, many things look like nodular fasciitis, tissue culture pattern, spindle cell, all kind of thing. But what will make you think of nodular fasciitis is the overexpression of USP6. I don't know, is there an IHC for USP6?
What is this?
Is there a USP6 IHC?
I don't know. It look more like a molecular.
Yes, molecular something. There are many things that resemble nodular fasciitis.
Right? T. CT.
So the USP6 overexpression distinguishes from other sarcomas and benign mimics. Let's go to histology. Histology, we'll look at histology visually before we come to look at anything here. So this nodular fasciitis mammography, of course, that would not tell us much. It rarely occurs in the breast. When it does, it's often subcutaneous, just underneath the skin, underneath deep muscle fascia, near deep muscle fascia. This case presented as a superficial mass of mammography. Nodular fasciitis subcutaneous. So that's one very, very good thing. It should just be someone underneath the skin of the breast. It's very important, usually less than 3 cm. Nodular fasciitis subcutaneous in the superficial breast, but usually located in the subcutaneous tissue near the skin, rather than within the breast. The margins are generally well defined, although there can be focal infiltration, like these tentacles here, spicules here, into surrounding tissue. Okay, but generally well defined pattern. Then tissue culture pattern.
Number 6.
So define tissue culture pattern.
It's just a loose arrangement.
A patternless pattern, that's what they called.
Yeah.
You shall know there's an arrangement, but you cannot very well define the arrangement. So is the cells are loosely arranged without a specific tissue pattern. That's called patternless pattern. That's tissue culture pattern. You can see focal walls or storiform formations. Focal walls. Or storiform formations can be present. Areas of keloid-like collagen are frequently seen. Nodular fasciitis, muscle fascia. Near skeletal, this is skeletal muscle. It can be a mass in the breast, close to the chest wall. The margins are well circumscribed or irregular. You can see mitotic spindles. There is usually a clinical history of rapid tumor growth correlating with the presence of frequent mitotic spindles. So the reason why we have mitotic spindle, like rightly said, this doesn't really look very pleomorphic. The only reason why we have frequent mitosis is because it's a rapidly growing tumor. And this can raise concern for malignant tumor. Atypical mitotic figures should not be present. I don't know what they mean by that. Nodular fasciitis may have extravasation of blood cells.
Exacerbation.
Yes,
Focal of exacerbation.
or blood cells that may enter the tissue. And they have what we call granulation tissue-like vascularity, composed of numerous small, thin-walled blood vessels. The extravasation of blood cells is a common finding. They may have some kind of granulation tissue formation. Then you have myeloid or ganglion-like cells. Multinucleated giant cells or myeloid cells can be present in neurofibromatosis. Nodular fasciitis, sorry. These ganglion cells with abundant cytoplasm, multinucleated, these look like ganglion cells. And they should not be mistaken for epithelial cells in a spindle cell carcinoma. This type of cells is more common in proliferative fasciitis and proliferative myositis. So they have ganglion-like cells, myeloid ganglion-like cells. Chronic inflammation is scattered throughout the tumor. In contrast to fibromatosis, in which lymphocytic infiltration is at the periphery. So in fibromatosis, which we are going to look at later, we are told that inflammation will be where?
Where is inflammation?
In fibromatosis, we are told that inflammation will be at the periphery of the tumor. Whereas in nodular fasciitis, inflammation will be scattered all through, chronic inflammation will be scattered all through the tumor.
Okay.
And ganglion-like cells can be present in nodular fasciitis. This is late phase of nodular fasciitis. When it begins to regress, it becomes paucicellular and the stroma becomes more collagenized. It is important to make a diagnosis of nodular fasciitis on core needle biopsy when possible. Patients can be spared surgery as the lesion will eventually spontaneously regress. What does that mean?
Patient can what?
Why is it important to diagnose it on needle biopsy, not on resection?
Because the patient may not need surgery.
The patient can spontaneously regress.
Yeah.
That's why it's important on biopsy service. If you miss it on biopsy service, what will happen?
The patient may have to undergo resection.
Yes, which is unnecessary.
Unnecessary.
Yes. So that's why. So what markers will you use to help you apart from the tissue culture pattern H&E?
Are you talking of IHC?
Yeah. Yeah, what axis will you use to help you?
Is that USPC my H9?
Already we saw something from the question we saw earlier.
Is beta catenin negative?
Beta catenin negatives. We say CD34 negative. How does beta catenin help?
You rule out fibromatosis. Fibromatosis is
Beta catenin positive, right?
positive.
Okay, CD34 rules out what? CD34 negative rules out what? Myofibroblastoma. Remember, myofibroblastoma.
Okay, myofibroblastoma.
You CD34
Okay,
positive. What else?
then which other lesion are we looking at?
Which of them is what is really positive in this case?
Oh shit. Okay, let's write it down. Okay.
I know the molecular, but it's not the USPC my MYH9.
Yes, MYH9. We said the tumor was positive for what? Smooth muscle
SMA.
actin, SME, but negative for pan-cytokeratin. There was this broad table that they brought out somewhere. All the spindle cell lesions of the breast are SME positive based on this table. You understand? So SME actually a marker of what? Mesenchymal proliferation, right?
Yeah.
So, but only one is CD34 positive, which is that?
To the myofibroblastoma.
Myofibroblastoma. Now, beta catenin is also a sign of fibromatosis. Now, beta catenin is a positivity, shows that there's a neoplastic process going on. But since this is the transient neoplasia, it will be negative for beta catenin, right? And don't forget that what kind of beta catenin staining will you find in fibromatosis? Is this cytoplasmic, nuclear, membranous? It's going to be nuclear. We're going to see that later. So this is nodular fasciitis on corneal biopsy. Vision will so if you can diagnose it, you have the tissue culture pattern, which is patternless pattern. Those mitosis, and then it will be negative for all markers except SMA. CD34 negative, beta catenin negative. Rapidly growing, painful mass. Let's continue.
Let's do number 5.
This is calponin. Why will we be positive for calponin?
Uru.
Calponin is myoepithelial cells.
Myofibroblast stands for, yeah, I can say myoepithelial cells.
Myofibroblast.
Yeah, because nodular fasciitis is made up of both fibroblasts and myofibroblasts, and that's why it's difficult. Since they're made up of fibroblasts and myofibroblasts, that's why it's difficult to rule it out from fibroblastoma, because fibroblastoma comes from they come from the same tissues, right? So you look at it now. When you have only fibroblasts proliferating, what do we call it?
Fibromatosis.
Fibroblastoma, right? If only fibromatosis, sorry. Sorry, forgive me, you're right. If only fibroblasts are proliferating, we call it what?
Fibromatosis.
If only my fibroblasts are proliferating.
Myofibroblastoma.
Yes, myofibroblastoma. And myofibroblastoma will be positive for what?
CD34.
And fibromatosis will be positive for what?
Beta catenin.
Beta catenin nuclear. People know that nuclear beta catenin. It's important to know that. Okay, good. So now, what if both fibroblasts and myofibroblasts are proliferating and rapidly? What would it be?
Negative for both of them.
Yes, and what disease would that be?
Nodular fasciitis.
Nodular fasciitis. I mean, I think it's a good way of remembering them. Mnemonics. Yes. So it will be negative for both CD34 and nuclear beta catenin. So let's continue. So this is calponin. SMA will also be positive, smooth muscle actin. Anything that says myofibroblast or something. This nodular fasciitis, CD34. Can you read this thing? Is it positive or negative?
Under the diagram.
Yeah, the diagram, yes. Is this positive or negative? These are, you can see the
Which stain is that?
CD34.
CD34 is a membranous stain. Yeah, it looks so.
Does it look positive or negative?
I'm not so sure.
You know all these things you see here, this is actually normal breast tissue, which is positive for CD34.
Which one is normal breast tissue? The one on top?
With this curved arrow. This is actually adjacent breast lesion, stroma breast lesion that has blood vessels. All these things here that are positive are blood vessels. Remember that CD34 stains blood vessels. These two nuclei here, these spindle cells that are here, are they positive? Are they staining or not staining?
They are not staining.
Yes. So you know, interpreting stains is also important. You may actually know that nodular fasciitis is CD34 negative, but go to the exam and these other blood vessels that are mixed with it, or some other things that are not the tumor, may stain positive around the tumor and may make you to miss the stain. You understand? You will think it's positive when it is negative. This happens a lot more in hempath. Hempath, where you're looking for large cells, popcorn cells, all those things. Miss multiple lymphocytes that are staining, but the large cells will not stain. That's very important. So CD34 negative. The endothelial cells surrounding it are positive. The margins are generally well delineated. However, there are areas of focal infiltration that can occur in nodular fasciitis. This is fibromatosis.
That's the shadow.
Fibromatosis. It's an example of fibromatosis. It's a very clear, very close mimicker. Fibromatosis can resemble nodular fasciitis. However, the tumor cells are going to be loosely arranged, and there will be mixture stroma that is going to be more common. The red blood cell expansion as well. So IHC stain will show what?
Beta-catenin, nuclear.
Very good. You have to use the word nuclear beta-catenin. Otherwise, if you see cytoplasm, you may see nuclear you may see beta-catenin staining that is cytoplasmic. That will not help you with you can't call it fibromatosis. It has to be nuclear beta-catenin to call it fibromatosis. Fibromatosis, peripheral lymphocytic infiltrate. How do you differentiate lymphocytic infiltrate in fibromatosis from lymphocytic infiltrates in nodular fasciitis?
If it is scattered in nodular fasciitis, but at the periphery in fibromatosis.
Yeah, the periphery in fibromatosis was scattered in this years, but the periphery in fibromatosis. Yes, you can see the aggregates, nuclear aggregate, very dense nuclear aggregate at the periphery. Unlike the aggregates you see in fibromatosis, nodular fasciitis are going to be scattered. This is the beta-catenin. You can see the spindle nuclei staining, spindle nuclei staining.
Let's trace the shape.
There are other lesions too that are positive for beta-catenin, so not only fibromatosis. This is myofibroblastoma. What was it? Can you kind of define myofibroblastoma histologically, how it will appear?
We have myofibroblast proliferation, and they are separated by collagen fibers.
Spindles, and they have to be well circumscribed. Okay, and what would that be positive for?
CD34.
Yeah, CD34 positive, nuclear beta-catenin negative. Okay.
What shape is this?
SMA positive, like others.
All of them will be SMA positive, yes. They'll be SMA
mesenchymal.
positive, yes. And that thing we missed, like you rightly said before, are hormone receptors.
Yeah.
So myofibroblastoma will be positive for what? ER.
Yeah.
Yeah, let's look at it here.
How about PR? I think it's possible for PR too.
I don't know about PR, but at least ER. At least that it should be also. They're positive for ER. So I think I'll do two stains if I want to call it myofibroblastoma. I'll do ER and PR stain.
I think this lesion is also one of those lesions that can occur in both male and female. Myofibroblastoma.
Okay.
I think that it can also occur in male.
Okay, we'll come back to myofibroblastoma quickly, and we'll see it quickly, and hopefully. Okay, it's got to be the middle female. This spindle cell carcinoma. How will spindle cell carcinoma differ from nodular fasciitis?
How spindle cell carcinoma?
Yes.
The anaplastic nature.
Yeah, it has significant nuclear polymorphism atypical mitosis. What else? What marker will help a lot to differentiate both? Cytokeratin.
Cytokeratin. So
Yeah.
spindle cell carcinoma, that's the one we are talking about next, right?
Yes.
It's also something, a spindle cell lesion of the breast.
And they can be positive for P63. And high molecular weight cytokeratin like CK14 and 17. Spindle cell carcinoma. This P63. P63 is really positive in spindle cell carcinoma of the breast. Nodular fasciitis will be negative for all kinds of microglial markers and cytokeratins. Synovial sarcoma of breast. It looks like synovium. Frequent mitosis. Exceedingly rare.
I'll sit down so we do take ice cream later. So letter S and letter H sound.
Okay, so synovial sarcoma of breast. Sorry.
I'll not give you ice cream. Oh. Come and sit down here. Come and sit down here. Letter S and
Okay, angiosarcoma, sorry.
letter S and letter H sound.
Angiosarcoma, okay.
H sound.
More
Atypical
cellular,
spindle cells.
yes.
Then you're going to have
More pleomorphism.
more promosing, and then you could have what's happened to the vessel?
Letter S.
The vessels will be
Anastomosis.
abnormally shaped, right?
Yeah, there's something too about those anastomosis. Is it anastomosis? It's not really anastomosis.
Yeah, they'll look anastomosis. You remember very well. Yeah, they'll look anastomosis and they'll be bizarre. They'll see this for 10-34 positive. You see a lot of bizarre looking vessels that appear anastomosis. The location of nodular fasciitis is also very important. It's either superficial or deep to the chest wall if it's breast. SME is going to be positive. Just like actin, just like which other one? What other one we mentioned earlier? Yes, SME is what's going to be positive.
Number 3 is what? Yes, we do that.
But that can appear infiltrating.
Number 3 is what?
This is fibromatosis again. Long swimming fascicles. Fibromatosis may recur locally. Now, all breast trauma tumors are CD34 positive. True or false?
False. That's false.
What are the ones that are CD34 negative?
Negative, okay. Nodular fasciitis, fibromatosis,
And fibromatosis. Only those two.
then about spindle cell carcinoma.
Spindle cell carcinoma, I think it should be CD34 positive. Because according to here, they are the only breast tumor that are CD34 negative. Angiosarcoma, of course, we CD34 positive.
Yeah.
This is myofibroblastoma, CD34 positive. Angiosarcoma has hemorrhage. It's sarcoma itself. Beautiful growth pattern. So that's all for it now. So let's come to quickly review the past things. So histologically, there are different phases of the nodular fasciitis. So we have the early phase, the mid phase, the late phase, and the mixed phase of nodular fasciitis. And the early phase, we have cellular abundant myxoid stroma with high mitotic activity. Mid phase becomes densely cellular, less myxoid. Late phase, less cellular, more fibrous and hyalinized. Finally, we have the mixed phase.
After we
Most
do
lesions show mixed
science,
face
I will blow
features.
balloon for you, okay?
Histology, you see
Vein,
spindle
balloon,
shaped to
this
stimulate
one is small.
myofibroblasts in short
Right.
fascicles or
Right.
walls. They will have the tissue culture pattern, which is disorganized growth, what we call patternless pattern. There'll be frequent mitosis, but the mitosis will not be atypical mitosis. If you start seeing atypical mitosis and significant pleomorphism, what will you start thinking of?
Atypical.
Mitotic figures and significant pleomorphism. What will you start thinking of?
Cell carcinoma.
Yes, and what marker will help you differentiate that?
Cytokeratin.
Which of them?
CK14, CK17,
What
and molecular keratin.
Yes, give us here 17. Is it 17 or 19? Let me see if I can find it. 17, you're right. Why molecular weight?
After this work, we'll blow balloon.
Molecular weight.
And it's vinegar we'll use, not water.
Then P63 also.
It's vinegar.
Myonucleate TPR can be found in this case. Mixture to fibrous stroma with extravasated blood vessels can be found. Chronic lymphocytic infiltrates are diffusely present. Microcysts. Which tumor has multiple Swiss cheese pattern cysts?
When we finish our rhyming, I'll blow this balloon for you.
Okay, multiple cysts, pattern cheese,
Rhyming.
juvenile.
Juvenile papillomatosis.
Okay.
So we have macrocysts, multinucleated myeloid cells, occasional bone metaplasia. Lesion is generally circumscribed, may have focal infiltration. SME, calponine, IHCs.
Okay.
It is still positive for myofibroblasts, such as SME and calponine. Desmin will be positive because the mesenchymal tumor. Cytokeratin will be negative. P63 will be negative to the large spindle cell carcinoma. Beta catenin will be.
Look for a word that rhymes with ma.
How we beta catenin stain nodular fasciitis? Yes or no?
Word that rhymes with ma.
No.
It stains it.
It stains fibromatosis.
What is this?
But it also stains nodular fasciitis.
What is this?
But it's cytoplasmic staining.
Okay.
That's why it's important to know the kind of staining you have with beta catenin.
So
why was it that in that question they said beta catenin negative?
they rhyme together, so circle it. Okay.
It may be completely negative for beta catenin. However, note that.
What is this? So can you look for a word that rhymes with car?
By the way, let's look at something first.
No. This is not. What is this? What is this?
No, not.
Okay, but this is not. And cashew nut. What is this? So car rhymes with jar. Both of them have AR. Number 3. What is this?
So let's look at beta catenin staining. If you understand how beta catenin is stained, it will help us to know positive and negative stains. So on a normal day, where is beta catenin located?
Nucleus.
No, in the cytoplasm and the cell membrane. If you look at this, our text here. Anytime you have beta catenin is never found in the nucleus. Anytime you have nucleus staining of beta catenin, it shows an aberrant WNT beta catenin pathway activation.
Yeah, look for.
So positive nuclear staining is when immunohistochemical staining shows nuclear localization of beta catenin. That means it diffuses into the nucleus. And that is found in greater than 5 to 10% of tumor cells, depending on the diagnostic context.
Look for which one.
The nuclear beta catenin staining is a hallmark of WNT pathway dysregulation. And it's associated with specific tumors like desmoid fibromatosis. You should diffuse nuclear staining in most cases, like the fibromatosis you are looking at here. Hepatoblastoma. Solid papillary neoplasm of the pancreas. Yes, that will show solid nuclear, sometimes nuclear and cytoplasmic, sometimes both.
Number 5, the last one.
You can actually have both nuclear and
Just hold
cytoplasmic.
on.
Do you know
I
that?
have to know some of this thing. The beta catenin, you see it in. Hello?
Yes, I'm with you.
Okay.
No.
So apart from fibromatosis,
No.
nuclear, you see it in
This is
desmoid fibromatosis, hepatoblastoma. Okay.
and
Okay. Yeah.
Okay.
I'm sorry, papillary neoplasm of the pancreas. Endometrial carcinoma. This thing nuclear staining in tumor cells with or without cytoplasmic staining. Positive.
So I didn't get what to say.
Hmm?
What did you say just now?
I said, normally you don't find beta-catenin in the cytoplasm, sorry, the nucleus. It's sorry, cytoplasm or membrane. If you find it in nucleus, it's aberrant. WNT signaling pathway aberrant. And note that beta-catenin can stain in some cases both nuclear and cytoplasmic staining. Okay.
Okay.
In that case, is it positive or negative?
In what?
If there's both cytoplasmic and nuclear staining,
Both. Would that be negative, Abby?
that'll be positive. Anytime you find it in the nucleus, it's positive. Okay. Are you with me?
Okay. Yeah.
Anytime you find it in the nucleus, it's going to be positive. Okay, so
Don't touch it.
negative means no nuclear staining. So if a tumor stains for beta-catenin, but the cytoplasmic staining, the nucleus is not stained, is that positive or negative?
It was the beta catenin, but the cytoplasmic stain is what? Sorry.
A tumor
Repeat.
is positive only for cytoplasmic staining or beta-catenin. Nucleus is negative. Is that positive or negative staining?
It's negative.
Yes, it's negative. That's what we have here. In nodular fasciitis, you can see cytoplasmic staining. You will not see nuclear staining. That does not mean that it is positive for beta-catenin. So you are going to report in your report that it is nuclear, actually cytoplasmic staining for beta-catenin, but nuclear staining negative, or negative for beta-catenin. And what are you trying to tell the clinician?
That you have ruled out effective.
Fibromatosis, yes. And CD34 will be positive, like will be negative, and that rules out myofibroblastoma. So
Hello?
rules out angiosarcoma as well. Yeah, I'm with you.
Okay, I'm listening.
So mention mention key differential diagnosis, 5 mimickers of nodular fasciitis. How are you doing, sir? Hello.
Fibromatosis. Sorry, I was muted. Fibromatosis.
Fibromatosis.
Differentials. Myofibroblastoma.
Myofibroblastoma.
Spindle cell carcinoma.
Spindle cell carcinoma.
What is this?
Okay. Well, do you want to consider vascular lesion like angiosarcoma?
Angiosarcoma.
That's on spindle cell.
Proliferative fasciitis, also called myositis.
Okay.
So let's look at how to differentiate it. Fibromatosis, what do you see in fibromatosis that will differ from nodular fasciitis?
Nuclear beta
Nuclear beta-catenin, very good. Myofibroblastoma.
But in HIE, inflammation is periphery in fibromatosis.
Very good.
Scattered in nodular fasciitis.
And diffusely scattered in fibromatosis. Sorry, nodular fasciitis, sorry. Okay, next, what else?
Myofibroblastoma, you have dense collagen in the stroma.
We have dense collagen, yes.
Then you have CD34 positivity immunohistochemistry.
And ERPR positive, both are positive. ERPR positive.
Yeah.
Getting bigger. Bigger and school.
Then sarcoma.
School.
That's anaplastic cells.
They will be larger than 3 cm. Now, nodular fasciitis is usually less than 3 cm. Sarcoma will be larger than 3 cm. And we have abnormal mitosis and significant atypia, right? Spindle cell carcinoma.
Yes, sir.
Again, can you hear that?
I can hear you.
That's a spindle cell carcinoma.
Mm.
Differentiate spindle cell carcinoma. Differentiate it from.
Hey, I mentioned the cells are anaplastic.
Mm-hmm.
Then what else? The IHC then.
Hyperkeratin markers.
High molecular weight cytokeratin, CK14, CK17 positive.
About P63 also.
P63.
Yeah. Then proliferative fasciitis or myositis. You have ganglion-like cells that are CD68 positive. However, there will be no USP6 rearrangements. What is the fish test? Fish fusion.
Sorry, what is the uniqueness of the hallmark of the proliferative myositis?
They say ganglion-like cells.
Okay.
And CD68 positive also.
CD68 positive?
Yes.
Like you have in granulosa cell tumor.
Like a granular cell tumor.
Where is the balloon? Where's the balloon? You bust it. I busted it. Eh? Where is the balloon?
Diagnostic pitfalls. Nodular fasciitis often mimics sarcoma due to rapid growth, high mitotic activity, poor circumscription. They may be misdiagnosed as spindle cell carcinoma and core biopsy. Especially, what can make somebody to misdiagnose nodular fasciitis or core biopsy as spindle cell carcinoma?
So you don't put everything in your mouth. Is this food? What is this?
So what can make you distinct? What can make you
that mitosis?
Apart from mitosis, in terms of IHC, from what we have on the screen?
I can't see what is on the. I can only see the diagram. I can't see the letters. Okay, sorry. Mitotic is not.
Yeah.
Okay. Cytokeratin staining is not done.
Oh, if you don't do cytokeratin staining, you may diagnose it as spindle cell carcinoma.
Okay.
Because, especially, you know that it is P63 positive. So there are some times where P63 may be falsely positive in some cells around the nodular fasciitis that may make you think that this is spindle cell carcinoma. But you have to do pan-cytokeratin. If cytokeratin is negative, that will more or less make you think of nodular fasciitis. But if cytokeratin is positive, you think of spindle cell carcinoma. Another thing is this. High mitotic rate in nodular fasciitis is not a marker of malignancy, provided there is no significant pleomorphism, no atypical mitosis, and no destructive infiltration. On mammography, you will see irregular spiculated mass that may miss carcinoma. Ultrasound will be hypoechoic mass that may show vascularity. And that is the location. What is the location of nodular fasciitis in the breast?
Nodular fasciitis in the breast.
Yes. Near the
Subcutaneous.
fascias, right? You will near the fascia, underneath the skin, or close to a deep muscle.
Okay.
What's the treatment? You do excision surgery if you're not sure to rule out malignancy. But if you are very sure, watchful with acceptable, observation, the lesion will spontaneously regress. Recurrence is extremely rare, and there's no reported case of metastasis in the breast of patients with nodular fasciitis. Prognosis is excellent and self-limited, and the tumor is non-recurrent. But high yield. We have looked at all this already. Let's quickly see fibromatosis quickly. I think we have seen fibromatosis already. We will not spend time there. And then we'll answer our questions and then fibromatosis. So this is fibromatosis. It still has the classification here, or the density here has spiculated margins that may resemble invasive carcinoma.
Okay.
What's the meaning?
What's the speculated margin? Like he's spreading or what?
Like star-shaped. Like see these tentacles, like claws. It's not like round, That looks infiltrating. It has an irregular border that penetrates into surrounding breast parenchyma and may mimic invasive carcinoma. On gross appearance, what tumor has Swiss cheese appearance on gross appearance?
Juvenile fibromatosis.
Yes. Firm tan mass with lobulated margins that are focally infiltrating into the tumor. This has long fascicles, almost like a neuronal fascicle. And this is very characteristic of fibromatosis, the long fascicles, long nuclei. Thick collagen bundles are there also. My fibroblastoma will be more well-rounded, actually. You see the lymphoid aggregates. Where do you find the lymphoid aggregates?
At the periphery.
At the periphery, yes. This one even has a germinal center. You see fibromatosis infiltrating around normal epithelium. This fibromatosis infiltrating around normal epithelium. Fibromatosis. This is perineural invasion. Perineural invasion is not an indicator of malignancy in fibromatosis because this is a mesenchymal tumor. It's just that the tumor may be spreading around nerves. This is muscle invasion in the deep chest wall. or needle biopsy. Blood extravasation of blood vessels may also be seen, just like in nodular fasciitis. The nuclei are the ones staining positive for beta-catenin. Look at this. Look at this. Which one is positive for beta-catenin? The one on the left or the one on the right?
On the right, but
Yes.
the left is cytoplasm, are we?
Yeah, it's not centralized, it's membranous. You can see like the cell walls of the membranes.
Yeah.
Membranous staining. This is nuclear staining. Right. Very good.
Carry your body back.
See this is CD34 staining, which is negative in these areas.
But it's membranous on the other area, on the left.
Unless it's positive. I think that my brother was, I think it's cytoplasmic also.
Ducts and
Yes, it's around the dot. Remember that epithelial cells epithelial breast tissue don't stain with CD34. Is
they
the
don't.
fibroblasts?
Okay.
Is the fibroblasts around it that stains positive? Yes, perimatosis. This is blood vessels staining CD34, but the myofibroblasts are sorry, fibroblasts are negative, but are desmin positive. All of them will be positive for actin, desmin, cytokeratin negative. Which one will be positive for cytokeratin? Which of the tumors? This, of course, cytokeratin will be positive in epithelial cells, but which tumor, cell tumor will be positive with cytokeratin?
In this sense,
Cell carcinoma, right?
okay.
Gardner fibroma. Gardner fibroma is associated with APC, adenomatous polyposis.
You poo-poo.
Gardner fibroma is mainly cancer. Let me say mainly collagen.
Hello?
Fibromatosis like metaplastic carcinoma.
Writing on the wall. What did you write on the wall?
What make you carcinoma?
Eh?
I said, what make you carcinoma? The hallmark.
Maybe because it's going to be cytokeratin positive. I don't know. I'm not so sure about this particular thing. Fibromatosis like metaplastic. It's a carcinoma that began to look like fibroblasts. That's why they call it fibroblastic. Somebody going to stain cytokeratin. That's why it's carcinoma. Right here you can see it's staining positive for cytokeratins. P63 here. If you look, normally for epithelial cell cancers of the breast, would there be P63 negative or P63 positive?
They should be epithelial cells, right?
Carcinoma of the breast.
They are negative
Yes. What are
because they don't have epithelial cells.
what are spindle cell tumors of the breast?
They are positive.
Yes. That's kind of strange. The spindle cell, you see, even that, so a spindle cell tumors of the breast can actually be P63 positive because they're mesenchymal tissues, mesenchymal tumors. And even though some of them have cytokeratin positivity.
Okay.
And this fibromatosis like metaplastic carcinoma may also be, it's also nuclear beta-catenin positive, similar to fibromatosis. Fibromatosis would be, this is spindle cell carcinoma. Atypical mitosis. Some of these things are so overlapping.
Just subtle differences.
Yeah, that's why we need markers. Myofibroblastoma. Time with a number. Biopsy site changes. You see hemosiderin macrophages and biopsy site changes.
This is what?
Have you seen biopsy site changes? I did a lot in my program. This is loosely arranged fascicles, patternless pattern, more circumscribed. This is PASH. Have you seen PASH before?
Yeah.
Pylorus.
Window what?
Pseudoangiomatous stroma hyperplasia.
Somatoplasia.
Lot of blood
You
vessels.
have clefts. You have spaces that are what?
Yes. Inside of dense collagenous stroma, something like that, or hyalinized stroma. 334 positive.
The
Filaris tumor
spaces are
is
lined
334
by,
positive.
is it,
Hmm? What did you say?
the spaces are lined by bland spindle cells. Abi? Or what's the description?
It's blood vessels. I think blood vessels are the ones that will form the spaces. Pseudoangiomatous, something like that. I can't remember. PASH.
Syndo, it means that it's not true blood vessels, but rather they are spaces. It
Yes.
don't look like
Particular variant of this is
master.
granular cell. No. This is collagen actually, not granular cell. Because if you go on
It don't
hyper,
look like master or something. Well, oh, no.
gynecomastia will not have ducts, and these are ducts. Oh, you're
Okay,
right. These
okay.
are gynecomastia in a way, but they call it, you're right. Call it fascicular variant of PASH. And the thing is that, can you tell me one thing about PASH that will differentiate it from fibromatosis? PASH does not form mass.
Mm-hmm.
If you know that the history is very, very important when we look at biopsies, they'll say breast mass. We know that scar, radial scar does not form breast mass. DCIS does not form breast mass. PASH does not form breast mass. UDH does not form breast mass. ADH does not form breast mass. Papilloma does not form breast mass. So when I say the breast mass, actually, it should tell you, it helps you to guide you what to start thinking about. So you say breast mass, this is not a breast mass, and I start seeing this particular like patch, like changes or whatever. This is, of course, this is phylloides. It will form breast mass. And phylloides has CD34 positive. Beta category nuclear positivity in fibromatosis. Regular border. Infiltration growth pattern at times. Biopsy site changes. You can infiltrate duct around epithelium. This is PASH. Regular border. Fascicles. Fascicles. Beta nuclear keratin negative.
Many do have.
Infiltrating borders. Lymphoid aggregate periphery. Keeping long fascicles. Nuclear beta catenin positive. Okay, that's all for that. So fibromatosis of the breast is actually a benign tumor. It's not a transient neoplasia. What are other names for fibromatosis?
What?
Other names for fibromatosis?
Fibromatosis. Other name. Okay. Desmoid tumor.
Desmoid tumor, aggressive fibromatosis, extra-abdominal desmoid tumor, and can arise from pectoralis fascia if you treat the breast. What are the two most common mutations in fibromatosis?
APCD mutation and beta carotene.
That's
CTNNB
beta
mutation.
catenin mutation with CTNNB1 mutations. What other tumors have CTNN mutation, CTNNB1 mutations?
Thank you.
Desmoid fibromatosis, hepatoblastoma, solitary papillary neocarcinoma of pancreas, colorectal cancer, endometrial carcinoma.
Very good. Let's see. Colorectal carcinoma. Okay, let's tumors with. Let's see if there's tumors with I don't know if this mutation always corresponds with nuclear beta-catenin staining. The WNT beta, you are right again. Desmoid trifibromatosis, hepatocellular carcinoma, solid papillary neoplasm of the pancreas, hepatoblastoma, endometrial cancer. They just added more things, but the same pathway.
1, 2.
So the CTNNB1 or APC mutation, not both. These are mutually exclusive. Do you understand? In terms of genetics, if you cannot have a fibromatosis tumor that has both CTNNB1 mutation or APC mutation, they are mutually exclusive. So if CTNNB1 mutation is present in fibromatosis, there will be no mutation in APC. If APC is present, there will be no mutation in CTNNB1. Take note of that because there are some tumors like that that have two mutations that are mutually exclusive and cannot coexist. As we go along, you will see that some tumors like that exist.
Okay.
Usually not painful, fair mass, rare in men, people in their 40s, associated with retracted skin and all that. So I think we are done with this.
You want us to answer question on that?
Yes, no, we're almost done. We're almost done. We're going to ask questions and then we'll close on it. Cell keratins, P63 negative. Okay, we've done all this already.
Let's do answer question and then we can take some break.
Okay, yes, surgical excision is treatment. Recurrence can occur and all that. Okay, let's come back here. I believe we have answered sufficient questions to distinguish these and the rest. But tell me anything you know about metaplastic carcinoma before we go on break. Our break is going to
It's the same as spindle cell carcinoma, right? Of the breast?
I don't know. Is that the same thing? I think so. Yes. Spindle cell metaplastic carcinoma. Not sure if that's the same thing. Metaplastic carcinoma, I think it should be the same.
It should be.
Yeah,
It's
let's
high molecular with cytokeratin. You see anaplastic cells, anaplastic spindle cells, high molecular with cytokeratin positivity, then PCC3 positivity too.
okay. Okay, good. Let us have our questions and then break.
First time, negative cytokeratin.
A spindle cell breast lesion is positive for SMA and negative on cytokeratin. CD34 and beta-catenin. What's the most likely diagnosis?
Nodular fasciitis.
Yes, that means it's a diagnosis of exclusion. It's positive for cytokeratin. What do we call it?
Metaplastic carcinoma.
Or spindle cell carcinoma, right? If it's CD34 positive,
Myofibroblastoma.
beta-catenin nuclear.
Fibromatosis.
Which of the following is a common clinical feature of nodular fasciitis in the breast?
It's rapidly growing tender mass.
Which marker is typically positive in metaplastic carcinoma but negative in nodular fasciitis?
The 3 and 7.
Pancytokeratin.
What feature is least characteristics of nodular fasciitis histologically?
7. Which one is more?
Least.
7.
High grade nuclear atypia.
Which spindle lesion of the breast typically shows nuclear beta-catenin positivity?
Fibromatosis.
What best distinguishes fibromatosis from nodular fasciitis?
Beta-catenin.
Nuclear beta-catenin. 60-year-old male with gynecomastia has CD434 positive spindle cell breast mass. What is the most likely diagnosis?
Sorry, which number are we now?
7.
Myofibroblastoma.
Which of the following markers is not typically expressed in myofibroblastoma?
Pancytokeratin.
Which histologic because desmin will be there, CD34, SMA, androgen receptor to AR. I forgot this. The androgen receptor positive as well. Which histologic feature favors nodular fasciitis over fibromatosis?
Phagocytosis.
Milk.
Tissue culture like spindle cells.
Milk.
Yeah.
Cream. Let's use cream.
What is the typical clinical behavior of nodular fasciitis?
Cream.
It's benign and self-limited.
What histologic feature may be present in nodular fasciitis and mimic malignancy?
Cream.
Mitosis.
What makes metaplastic carcinoma a challenging mimic of nodular fasciitis?
SMA expression, spindle cell morphology.
Yes. So, but the cytokeratin will help us to rule it out. What immunohistochemical profile best supports the diagnosis of nodular fasciitis?
Extraction of duct and lobus. Fibromatosis.
Look at number 13. What immunohistochemical profile supports nodular fasciitis against the rest?
So the number,
13.
what necessary problem both this is nodular society. D.
The SMA positive, cytokeratin negative, CD34 negative, beta-catenin negative. Which spindle cell breast lesion is most likely to show entrapment of ducts and lobules?
Fibromatosis as an infiltrative pattern.
A breast lesion shows short fascicles of spindle cells, red blood cell transversation, SMA positivity. What additional feature will support nodular fasciitis?
Yes.
Negative cytokeratin staining.
Okay, so well, I'm going for prayer in the next hour. I'll be done by 12 by 11 o'clock your time. What time will you be available then? Will you be available by 11:30?
Okay,
That will be 2 hours from now.
it's all right.
You try to catch some rest too. Okay, thank you, sir.
Okay, thank you. Good.
Bye.
I think I can leave here. Yeah.
Huh?
That's lemon.